Good afternoon, everyone. A warm welcome to you all to this shoulder and knee sports injuries symposium. We are very grateful to our chairman, Sri Ravindra Rao sir, managing director, Dr. G.S. Rao sir, Dr. Pavan, director, Yashoda Hospitals, our unit head, Dr. Sunil Bidayat, and his admin team for the unconditional support and resources provided for this educational program. This is a unique workshop being conducted by Elite Orthopedic team of Yashoda Hospitals Hitec Division and TONABOLIC's fitness team of Miss Ashrita Datta. This educational program is special and different because it is not one-sided lecture. It is an interactive program which includes delegates from different walks of life like sports coaches, athletes, physiotherapists, fitness, rehabilitation professionals, patients, and health professionals. 5 specific topics will be discussed, including the nature of the injury, surgical treatment plan, physiotherapy, and return to sports after undergoing fitness and rehab program. We wish that you all actively participate in the discussions. Feel free and without hesitation, just clear your doubts or any queries. Now I would like to introduce our Elite Orthopedic team. Elite Orthopedic team has 4 consultants who specialize in subspecialty work. It is one of the very few teams in the country which believes that the surgeon should focus in one area of orthopedics and not be a general orthopedic surgeon. Firstly, I would like to introduce Dr. V. Ram Mohan Reddy. Dr. Ram did his undergraduation from Usmania Medical College, Hyderabad, and MS Orthopedics from the prestigious National Institute, PGI, Chandigarh. In the United Kingdom, Dr. Ram completed higher surgical training in the orthopedics, achieving FRCS orthopedics and CCT. His personal interest in biomechanics, materials, and metallurgy resulted in Dr. Ram achieving MSc Orthopedics Engineering degree from Cardiff University, UK. Dr. Ram and Dr. D.N. Reddy are among the very few surgeons who have dual degrees of FRCS Orthopedics and Masters in Ortho Engineering to their credit. Dr. Ram did advanced fellowship in complex primary and revision lower limb arthroplasty and knee sports injuries from the world famous university Hospitals of Canberra, Australia, under the guidance of Professor Paul Smith. Dr. Ram worked as a consultant in Grantham Hospitals, United, Lincolnshire Hospitals, NHS Trust, and returned to Hyderabad to continue his practice. Grantham is a small town in central UK where the famous scientist Newton was born and was the constituency of the former Prime Minister Mrs. Margaret Thatcher. Dr. Ram specializes in knee sports injuries, and Dr. Ram will speak about ACL and meniscal injuries today. Dr. Ram does complex primary knee replacements. If you can see there, that's a deformed knee with dislocation. For that, primary knee replacement done. And that's a malunion tibia for that primary knee replacement done with by using long stumps. And that's a revision knee replacement done for failure of primary knee replacement. He also does complex primary hip replacements. And that's a hip replacement done for the hip that was dislocated for 50 years. And the hip replacement done for severe osteoarthritis of the hip. And revision hip replacement done for failure of primary hip replacement. Now I would like to introduce Dr. D.N. Reddy. Dr. DN completed his undergraduation from JSS Medical College, Mysore, and MS in orthopedics from the prestigious Usmania Medical College, Hyderabad. In the United Kingdom, Dr. DN completed higher surgical training in orthopedics, achieving FRCS orthopedics and CCT. His personal interest in implants design, biomechanics, and materials resulted in Dr. DN achieving MSc Orthopedic Engineering degree from Cardiff University, UK. As I mentioned earlier, Dr. D.N. Reddy and Dr. Ram are among the very few surgeons who have dual degrees of FRCS Orthopedics and Masters in Orth Engineering to their credit. Dr. D.N. did advanced fellowship in complex primary and revision shoulder replacements, shoulder, elbow, and wrist sports injuries from the world-famous University Hospitals of Mayo, USA, and Sheffield University Hospitals, UK. Dr. D.N. worked as a consultant in Leicester University Hospitals, NHS Trust, and returned to Hyderabad to continue his practice. Dr. D.N. travels widely and he is a faculty in national and international conferences. His work is mainly complex and revision shoulder and elbow replacements, sports injuries of the shoulder, elbow, wrist, and also does complex fractures fixation of shoulder, elbow, and wrist. Dr. D.N. specializes in shoulder sports injuries and he will speak about rotator cuff injuries and shoulder dislocations today. He specializes in reverse shoulder replacements and shoulder replacements for arthritis and fracture. If you can see there, that's a reverse shoulder replacement done for rotator cuff arthropathy and shoulder replacement done for the shoulder fractures. Dr. D.N. is an expert in fixing badly comminuted shoulder fractures, and that's elbow fracture fixation and wrist fracture fixation. Dr. D.N. is among the very few in the country who does elbow arthroscopy. Now I would like to introduce Dr. Amit Reddy. Dr. Amit did medical graduation from BLDE Medical College and MS in orthopedics from Apollo Medical College, Hyderabad. Dr. Amit completed his MCH orthopedics from Seychelles. Dr. Amit did his fellowships in arthroplasty, sports injuries, foot and ankle surgery from Chronic Care Foundation, India, and HFR, Switzerland. Dr. Amit does pain management for disc problems, and he will speak about spinal epidural and foraminal injections for disc problems today. He is one of the few surgeons to do arthroscopy, that means keyhole surgeries of the ankle joint. And if you can see there, that's a arthroscopic subtalar fusion done for severe arthritis of the talus. Dr. Amit specializes in knee, foot, and ankle deformity correction surgeries like HTO and hind foot fusions. And that's a deformed knee. After high tibial osteotomy, deformity was corrected. And that's a hind foot fusion for deformed foot. Dr. Amit is an expert in OATS procedures and subspecializes in regenerative orthobiologics treatment like ACI, PRP, and stem cell therapy for knee, foot, and ankle cartilage restoration. That's a OATS procedure done for the osteochondral defect in the knee joint. Now I'd like to introduce Dr. Nitish Bhan. Dr. Nitish did MBBS from MRMC Medical College, Gulbarga, and later completed in MS in orthopedics from Kamineni Institute, Hyderabad. Dr. Nitish did advanced fellowship in minimally invasive lower limb arthroplasty, arthroscopy, and limb reconstruction from Southwest Military Hospitals, Chongqing, China. Dr. Nitish is passionate about hip surgery. He specializes in direct anterior approach to total hip replacements, and he is one of the very few in the country to do a high volume direct anterior approach total hip replacements. And that's one of the procedure done by him. That's an anterior direct approach. Using anterior direct approach, that's a hip replacement for severe osteoarthritis of the hip. Dr. Nitish other interests include complex articular fractures of pelvis trauma and distal tibia fracture fixations and distal femur fracture fixations. Dr. Nitish Bhan also specializes in limb deformity and lengthening procedures in upper and lower limbs. This upper limb lengthening procedure, this is before surgery. If you can see that left arm is shortening compared to right one. After 3 years of surgery, limbs are equal. That's a femur length procedure and tibia lengthening procedures. Now I would like to introduce TONABOLIC's team. I would like to welcome Ms. Ashrita Datta and her team who have collaborated with us to organize this educational program. The team motto is Target, Train and Transform Lives. Mind and body fitness training is based on scientific evidence. Training is customized to individual needs and health factors and improves strength, endurance, speed and agility. Rehab programs are included for those with special needs. Ms. Ashrita Datta is a certified fitness entrepreneur by passion and choice. Ms. Ashrita is an alumni of GE Capital, SBI Credit and Vodafone and leads a team of 20 plus certified fitness professionals. Her team was awarded the Best Startup of the Year 2022 by Business Outreach. Now, I would like to request Dr. V. Rammohan Reddy to start the speech.
Right. Good afternoon. I welcome all of you for this very innovative educational program. How did the idea start? I trained with the TONABOLIC's team led by Ms. Ashrita Datta. Mr. Azhar, where are you? There. He is the culprit who has made this happen. When I was training with him, at 6 o'clock in the morning, he asked me a question, what is ACL, sir? So I picked up my phone and showed, this is ACL. How does it look like when it is torn? Then he said, why don't you teach us? I said, okay, fine, I'll come to your office. A couple of hours later, Ms. Ashrita calls me and says, why just us? Why don't you take it further? There are so many who need this awareness. So it started with a small chat and we are here today. It's a privilege to see most of you here with an interest in learning. I also see the legends of sports here, Mr. Maxwell, 10 times national cycling champion and an Olympian. All right. I see Mr. Sunil Menon, the first Ironman of the state. He has been an inspiration and guide for my son, who is also an Ironman. All right. Mr. John and Mr. Srikanth, who are the national swimming coaches of Zion Sports. Aruna, the legendary gymnast, and her coach Manoj Rana. And one of the biggest cycling groups of Bike Affair led by Krish, Gokul, Sampath, Chitti, and many more. All right. I've been associated with all of them because I used to take my kids for swimming, cycling, and many more sports activities. Over the years, I've seen injuries happening to athletes, to the common man, road traffic accidents and all. As a surgeon, I have my limitations. Once a surgery is done, I don't know what to do next. So I hand it over to the physiotherapist. Physiotherapy have got their own limitations. They do exercise for the joint that is operated. And what next? When do they return to sport? So there are gaps in the treatment process. So the combination of the surgical team, physiotherapist team, and the rehab team, it's very important for complete recovery of a patient. It does not matter whether it's an athlete or a non-professional sports person. For the recovery to complete and compete at the highest level, the process has to be proper. I request Ashrita to come over onto stage and start off with her Tonabolics team work. Thank you.
A very good morning to all of you. Am I audible? To the last man standing right there, or seated right there. Fantastic. Thank you. A very good morning. I think I would like to first start by thanking Dr. Ram Mohan Reddy himself and the pretty lady who's taken a lot of effort to go by each doctor and explain as to what is the background, how well read is each one of them, who's contributing to the learning chapter that you're going to basically go through today. So while you introduced beautifully, and thank you, Dr. Ram, yes, this was true. It really transpired like that. Honestly, I was being jealous of Azhar, that why is he going to learn alone and why am I not going to be left behind? So I had to make sure that Sir does it to a forum at that large a quantity so that, we all benefit from the kind of learnings that has, emancipated over multiple years of his work in this field. Not just that, I think even Dr. Deepti Nandan, and I think all of doctors who are going to really go about this path of educating all of us today. We're going to, let me first begin by the next 20 to 25 minutes with you, if possible. And I'm going to, first thing first, introduce all of you all with all of you all, which means I want to understand what's the mix today of the people that we have. Can we just do a hand raise of how many doctors do we have in this hall today? How many doctors? A few more, all the hand raises, fantastic. That's a good group. Thank you so much for just being there. And you're adding a lot of vitality to us. How many coaches do we have in the group today? I see a big, nice show of hands. There are a lot of coaches over here today in terms of growing. Thank you so much. How many people who've undergone surgery or are likely to think about surgery or just about undergoing physiotherapy right now? Can we have a show of hands, please? That's very useful information. So hopefully you should be able to learn a lot from, what's going to be said today. How many of us are enthusiasts who want to learn more about bodies and how they function? We have no challenges as such. But yes, we're neither coaches nor doctors, but we are great people who are very interested in the art and functionality of the body. A few show of hands, please. Fantastic. That's the biggest group I see. So I clearly see a lot of people who are going to be keen on learning. So I'm going to be mindful that I try and use less technical terms so I don't kind of leave you confused. In terms of, how is it even relevant and what does she really mean when she says this complex muscle group. So we're going to begin first. Let me begin with the first slide that I'm going to bring to you. Thank you. That would really help me move. Can I? Thank you. Am I audible? Yeah, pretty much. Okay, so how do we transition the slide here? I'm still a little technologically challenged. Thank you. Okay, the first question that I'd like to ask you is, Of course, you're going to learn a lot about surgery. You're going to learn a lot about how this functions in terms of physiotherapy and how do we kind of get out of these challenges and body aches and movement challenges that we face. But I'm going to limit my conversation to my domain of expertise. And my first question to you will be, if one has gone through surgery or physiotherapy, what should really one desire right after that? And the question has two options as answers, which is pain-free body movement, your ability to move this body without pain. Is that what you should be aspiring to aim? The other is more than movement. Would you want more than movement? Now, in order to do that, I'm going to request a small activity here, and I will urge all of you to come up and stand from where you are. Can we? Thank you so much for raising yourself off the chair right now. Now, considering you're all going to be in this space, I'm going to request each one of you to walk the way you feel you can. But nonetheless, you're going to turn right from here. So you're going to make this turn. Give me 3 steps, 1, 2, and 3. Turn from here and give me 3 steps back, 1, 2, and 3. Come back, stand exactly where you start from. Let's do this together. We are going to start this stop. We're going to start this together. Turn. Let's walk 1, 2, and 3. Turn all over again. And we are going to walk 1, 2, and 3. Come back to right where you are. Thank you so much. You're really moving to my instructions very well as a unit. So I'm going to make a few instructional changes for you today right now. We are going to do a few things with our body, and let's start with our head. Let's take our head up. Let's begin by looking down. This time when you go up, appreciate the ceiling. It's really well done. Now this time around, you're going to look forward at me. Give me a little chin tuck and maintain that. Now think about your shoulders. I want you to relax those shoulders. Walk down with your fingertips at the side of your thigh such that you have depressed shoulders. Now while you have depressed shoulders, your fingertips should not be able to walk down any further than just that. That means you've depressed your shoulder fully. Now think about your shoulder blades. Imagine your pant has 2 pockets right behind right here. You're going to try and draw those shoulder blades into the back pockets of your pant. Can you do that? There's no visual change that any one of us will see, but you will know how you've drawn those shoulder blades into the back pocket of your pant. Think about your ribs now. Think about those ribs as if there is a front single pocket in front of your shirt. You're going to collect all those ribs together virtually, imagine, and you're going to tuck them into the front pocket of your t-shirt. Right with that, imagine virtually you're wearing a belt which has 4 holes in it. You're going to tighten this belt to the hole number 3. So brace your core. Right from here, if you've got a slight forward shift, lengthen that thigh. Open up the knees. Get a hip distance wide stance off your feet. Fantastic. I'm going to do a quick revision. Chin tuck, depressed shoulder, shoulder blades into the back pocket of your pant, ribs into the front pocket of your t-shirt, belt tight to 3rd hole, lengthened legs, and brace your core. This time around, we're going to repeat exactly. Hold this position for yourself. Make a small turn. Give me the walk 1. In the same position, maintain all of that. 2 and 3. Now turn around. Maintain all of this and begin back walk with 1 and 2 and 3. Fantastic. You've come back to where you are. I want you to get seated again. Thank you so much. So all that you did right now was a simple rejig of the postures that you carry for yourself, and you walk with it confidently. What I wanted you to feel is your body hasn't changed. You've just realized what to do with those right postures. And does anybody want to answer this question for me? My question to you is, what changed from your first walk to the second walk? Can we have the mic travel to where somebody chooses to respond? Thank you. Does anybody want to let me know what did you feel went differently from your first to the second walk? Can we have show of hands? Come on. Be a sport. You were more conscious of your posture. Thank you so much. That was meaningful. Who else wants to go with it? What did you feel was different? Yes.
Posture, alignment, and also like your shoulder blades and also your hips in alignment, like a chain.
Like it was a kinetic chain which you brought to use.
Yes.
Fantastic. Good observation. That lady right at the back, she wants to answer.
Initially, it was so relaxed walk, but later it was so conscious on our posture.
Yes. I agree, you were conscious. But can I say that you were mindful? Okay. So if you went mindful, there was something that changed possibly with you. But yes, you were always conscious. Any other thoughts on this? Yes? Does somebody want to answer there?
The quality of the moment.
Thank you so much for saying so. I think that I was waiting for this answer to come through. What happens when you start working? Unfortunately, a lot of our challenges are not faced by virtue of that 1 hour workout that you do or you don't do. It's your 24 hours, out of which you sleep for about 7 or 8 hours, the remaining portion of your day and how you lead that day and how you leave your posture to be attributes to so much more. So as she said, we improve the quality of our walk, just 3 steps back and forth, just by being mindful. So thank you so much for all of these answers, and each one of them made a lot of difference to me to understand how does it work for you. So I'm going to use this opportunity to call upon stage one of my senior team members, Harsha. And we're going to have, let me introduce Harsha to you a bit. He is an engineer, a qualified engineer who chose to be a fitness coach by virtue of passion. So he did his various certifications. In fact, he's got multiple certifications to his belt, starting right from a master functional trainer. He went on to also go ahead and do an animal flow instruction course. Right after that, he's also a rehab specialist, apart from being a strength and conditioning coach. So Harsha, let's have you over. I'm going to use this opportunity to introduce a few more cases to you and how did we sort of deal with it. But before that, here, Harsha. So before I even we begin talking about more about your cases and how we kind of dealt with it, and we dealt with it as a team. This proud team that I am going to be introducing you to in a while from now is the team which has also contributed along with Harsha to some of those rehabilitative conditions that we were able to fix for certain people. Harsha, I wanted to kind of ask you, what do you think is our approach or your approach when you look at a post-surgery case or post-physiotherapy case and you're likely to begin the person on strength and conditioning? Because a physiotherapist role is very critical to be performed by a physiotherapist, and we bring in ourselves right after that.
Thank you, Ashrita. Am I audible? Okay, cool. So thank you everyone for being here, and it's been something which we were looking very forward to. And thank you, Azhar, for making this, start this initiative. And so whenever we talk about something like assessment or anything post-recovery or injury, so we at TONABOLIC have a unique and a very comprehensive approach. Of course, physical therapists and physiotherapists have their own contribution, and which is very, very vital after the surgery. Okay, thank you. So, oh, now it's better. So, so after the doctors have done their magic, like, of course, like doctors like Dr. Ramohan Reddy, I've trained with him, so I've got to learn a lot from him. Not just about how to just train, but how to understand a person or a patient for that fact. We usually call them clients, but so when they come to us, so they are not just physically or just movement-wise they are compromised. They also have gone through some emotional trauma as well. So it's very vital to understand how important it is to see where they are right now at point, and then how to take them from there and how to push them. So coming back to the assessment at Tonabolic, so we prioritize the importance of doctors, clinical reports, and medical. Sorry. Okay. I thought he was asking a question. Sorry. So when we come to the medical reports and we see the diagnostic reports of the doctors, and also when there is a condition, like a specific condition, like a recovery from injuries, like
He's fine at the moment.
which is not so oftenly seen in fitness trainers situations or scenarios. We often are just trainers who want to make people lose weight or get shredded, or maybe want to build some 6-pack or 4-pack abs, like make them look happy when they're like want to shred like 20 pounds or something like that. But this is like a completely whole different scenario for us, and a way it's like getting into a different category altogether, combining and collaborating with physiotherapists, and then also understanding the vital role they play during and after the physiotherapy and the recovery. So when we start with assessing their risk assessment, which we call as a general assessment, where we see their posture, how their posture is, as Ashita just explained, and few of you also mentioned how you felt the shoulder blades being aligned and everything. So unfortunately, that's not the case. Even we see in the gym. Oh, thank you so much. Hello? Yeah, okay, this is better. So that's when we also realize, even not also during the injury or surgery, even after that, what happens is a normal person can also unable to do a shoulder retraction or a protraction or elevation or depression. These are very new terms, which is nothing but a shoulder circle. This involves all the movements, but unfortunately, we are not trained in that way. Unfortunately, we only think about, okay, how much I'm going to bench today. If I'm a bodybuilder or a power lifter, how much I can bench today. Or if I'm a guy who wants to lose my tummy fat, okay, how much I'm going to run today. So only few people, only very certified professionals or people who involve in these things have this understanding of how the biomechanics works. So when we start our assessment, we give most of our priority to the posture first, see how it is aligned, because your body talks a lot about you. Your movement, the way you move from one place to other place. As talking about movement, for me, basically, for us at Tonabolic as well, movement is something that is very crucial, because it's not just starting or lifting a X weight for X number of repetitions, and then you are done. You can go home and you're done with the movement. It's not just the 1 hour workout that you do at the gym, it's the rest of the 23 hours that you spend. That is what is very crucial, and that is what we want to teach our clients. So talking about this, we also covered the muscle imbalances, and when it's about muscle imbalances, we focus on teaching the clients how important it is to learn what can be improved in your aspect, what can be like strengthened in your case, and then slowly teaching them to blend the movements into their regular activities. So to talk about this more, I want to share some real life examples, which Dr. Ram has referred us, and we were able to do a little bit of justice to this, and I would like to show that on the screen now.
So, can we get the screen back? Thank you. So the first case that I'd like to talk to you about, Harsha, is that this is Shweta. We'll of course play this video as well for you in terms of what she thinks. But then when we started working on her, she was diagnosed with a disc bulge of L5 and S1. So it wasn't necessarily an accident, but then she faced it as a consequence of series of things, which is usually a case of accident that we encounter a disc bulge. That said, it was such a prolonged pain for her that by the time she reached us, she had extreme pain in her back, but then most importantly, even activities like sneezing would get her to hold her belly such that her lower back should not pain. So she was in a lot of pain. So at that time, Harsha, what did you think in terms of the observations that you, and what was your approach as such? Most importantly, there were two coaches who were working on this particular client. It was Harsha to start with, and in later phases, we also had Sapna. Would you want to stand and probably wave to the crowd around? And she was also working on this case. So all over to you, Harsha.
Yeah. So as we said, we started with a initial assessment, and after her post diagnosis, Dr. Ram has referred to us. So we had her medical report and the diagnosis report, where it was said that there was an annular disc bulge. And then we started by looking at her posture, as I told you. So her gait analysis, for instance. So when I was looking at her, there was a clear shift of pelvis to one side. So I usually, we won't take like every minute detail and start working on a rehab. But in her case, because she has a back pain, so we considered it as in a gait analysis, so X, Y, Z was the points which we discovered. So the next was the muscle imbalances in the gluteus medius was something which we found when we were doing a squat analysis. Also, she had a very dominant quads, which I didn't mention here, but few of the things. Like, it's not something which contributed in a single instance. She had a baby in 2012, and then in 2017 she had twins. Her core was completely weakened. It was a C-section. So when I was making her do glute bridges, it was completely like an arched back. It was nothing from her hips. So we emphasized on glute activations more. Then we emphasized on activating of the medius more. Then a couple of inner and outer thigh mobilities and activations. Followed by slowly, we were able to make her understand how her pelvis works, how she can actually move her pelvis anteriorly and posteriorly easily. And then we made her realize, okay, this is how your body works. It doesn't have to be a restricted walk. You can move it in a better way. And then we started making her do a regular squats, a single-legged movements, unilateral workouts. And slowly, we were able to bring her to a position where she was able to do plyometric movements as well, like box jumps, burpees, which she was very afraid because even while sneezing, she has to hold her core because it hurt her back very much. So we were able to significantly bring her back to strength and conditioning. But there was another challenge with her neck, which fortunately, Coach Sapna was in time to understand it, and she started the neck strengthening. But it is a case of something which, again, is something we can't deal it in 1 or 2 days. We have to diagnose this properly. Maybe if there is a possibility of something more than what we can handle, we have to refer it to a physiotherapist or to doctor again.
So let's hear it from Shweta herself. It's a small video. Can we get the audio to the video?
Ram Mohan. I came to him in around January with a chronic problem with lower back ache. It was not creating a problem in my day-to-day life, but it has been around for 3 to 4 years on and off in certain moments, like when I sit or when I get up after sitting for some time. We also did MRI, and there were few problems with my L5, S1 and T2. Although according to the doctor, it was more like normal problems. With aging, he suggested that the pain is there because you don't have your muscles around these areas trained well. I'm somewhere in my journey. After last 4 months of training, I definitely have reduced or mitigated pain in multiple movements, especially on my lower back area. And recently I'm observing little bit more problem with my hand and neck area, and we are focusing on neck strengthening. A lot of this has happened with a lot of careful training with quads, hamstrings, and the personal coach is really paying a lot of attention to the pose. It really helps out with the personal coaching. They pay attention to so many minute details. They really make you feel how many small muscles, small or big muscles you really have.
That's about all. It was a brief video. We kind of kept it short. But you get a gist of how she felt and how she kind of moved from a chronic back chapter to how she's today able to address that thing. But then it's work in progress and we still have neck issues to address. But then she's better on her back a lot more than now. Moving on to the second case.
Was referred to TONABOLIC.
Moving on to the case number 2 is we've deliberately, in order to maintain the confidentiality of the patient, we've removed the name and changed the name. But nonetheless, it's very important. I think this particular patient is very close to our heart, and we can't thank Dr. Ram Mohan Reddy any less for having had done this kind of a surgery for this lady, because let me explain you what really happened to her. She accidentally went from the 4th floor down to the ground floor in a shaft of like the elevator shaft, like a lift shaft. So there wasn't a lift and she fell straight down. Multiple fractures. I don't think we can even count and probably say how many bones were not broken. There were definite nerve damages. Clearly mobility, let's not even talk about mobility. It was clear case of fracture. We couldn't have imagined ourselves or our lives being impacted by something like this. So massive trauma case. Now while it's a trauma case, when she was sent to us, she was also emotionally broken. She was in a stage where she did not know life can come back to her the way she is. But I must tell you, had that surgery not been done, and a few things around, and rather corrective surgery. She'd gone through a surgery in the past, which didn't fare very well. Then Sir did a corrective surgery on her, and the ankle was also fused. So her left foot ankle was fused, because if it was not done, even a futuristic possibility of walking would not have been possible. Then she had multiple, so also her left shoulder and right elbow had fractures and various solutions done to be able to make her kind of move those joints. So if that was the situation, and that's where we started, we had not dealt with something as devastating as this. So Harsha, while you went through the assessment, what did you really feel was your approach towards addressing this?
Yeah, so as Ashrita said, this is a really close, it's very close to our heart case. I mean, I personally had a very strong bond with this client. Moving on, if I'm fumbling, it's because of you guys. It's not because I'm emotional, okay? So I didn't expect this much audience. So yeah, okay, so now when we started the assessment, of course, I have never expected in my life when I started my fitness trainer certification or finished it, I would get a case or I have to deal with something like this. I really have to appreciate the doctors and the physiotherapists who does this kind of work every single day, day in and day out. So when we started, initially after seeing the diagnosis report and everything, what we did was, instead of looking at the things which we can't work or move, we started building on strength where the aspects where we can work on. Like her shoulder was not on a full range of motion movement, but still she was able to move it. We could work on her knees, we could work on her hip. We were not able to work on her ankle because one is fused and the other is, like, again, operated. So there was also a case like her left feet was completely fused and her right ankle was still was a normal surgery, but then it was suggested by Dr. Ram that maybe in the future we might have to fuse that as well. So when we started with simple activations of her core. We started with Kegels. We started with scapular activations, which she clearly lost from falling down and the surgery. So her complete upper trap was dominating. Like her left shoulder was completely high and she was not able to lift her hand completely up in the air. So we started with activations, we started with soft release, and then we slowly built her into doing squats and walking. And when we got to her ankle, so that's when we realized that it's a case of edema. She had swelling, and we had to consult a physio. We had to bring in and then take further from there, which went really well, and she was able to at least walk. So for seeing a person who was in a wheelchair and seeing her walk was a big journey for me. I think it was the time of my life, and I will never forget this case. Even at the team, people who have like helped in this with me, and there's another coach, Ansari, and then there's Nikita, who's a physio. And we three, I really think this is something we are very proud of. And I would like to see what Spandana looks like now.
Yeah, so let's look briefly at, even before that, I think I must tell you that she spent about 3 days in a week working out with us, but she was also working the other 3 days of the week doing the homeworks that they were leaving her with. We had lost hope that she's not going to get her pelvic muscles back. She would very often during the sessions, she would not know, but unknowingly, because she had no nerve connection, she would probably have certain leaks. But what happened was we did not give up on Kegels. We just did not leave on Kegels. And there was this one odd day when she could activate very remotely, but she could still activate her pelvic. And it was thought that she's not going to be able to hold the pelvic muscle floor at all. But she was able to at some point in time, of course much later, maybe by the month 5 or so. But I think thanks to the team which continued to press, this has to be done, and there is a revival. Maybe there was a ray of hope by means of certain nerves which still probably could act to the stimulation. Let's look at this video. I think thank you so much. I think this clap is literally for her and how she fed and the kind of warrior nature that she carried, and she kind of worked on. Thank you so much. This means a lot, and we'll probably have her communicated that from wheelchair to be able to walk back, and it means a lot. We're moving on to the third case. Again, something, and this is the last case, and before we get back to talking to you closely, sorry. This is Sunila. So when we began with her, she had chronic neck pain. When I say chronic, almost for years together. But then the reports did not show that she had something such a big problem that it needs surgery. She did not need surgery. So Dr. Ram was wise enough to let her know that she needs to invest in her strength and conditioning. And what really transpired was, this is a typical case of how occupational challenges can keep us constantly in pain, and we wonder that we really have something massively wrong with our bodies. So she's a teacher, and she teaches in a college, long hours of teaching. So typically what happens is, and I think Dr. Amit Malik and me were having a word the other day where how teachers, and we should think about a separate module as to how do we address teaching and the kind of challenges they face. So imagine you're writing with your right hand with a chalkboard, and this is the position that you're constantly at very often. So what is happening? You've elevated your shoulder. Remember the shoulder depression that you did? Well, that's a good place to be. But if your shoulder is constantly active and you're constantly lifted with your traps, that's a challenge. So in her case, her profession posed a challenge that for multiple hours of teaching, there was a natural overuse of traps. So every time, I think even before I start talking about the solution, Harsha, what did you probably do in terms of diagnosis, and what was your approach with her?
Yeah, so in this case, we started off with a regular initial assessment, and it seemed that she have a very flexible body because she has been practicing yoga for very long. And the problem with most of the yoga, whoever practices yoga, is that they have flexibility and range of motion, but no control whatsoever in that end ranges. So if I ask a person to split, they'll like boom, fall down, but they don't have any control of like going down. If I ask them to squat, they'll just fall down and stand up. They have no control during that movement. So what we initially started is we started with a little bit of strength training and also asking her to correct her posture. As ma'am mentioned, it's clearly a occupational hazard. Like we used to release a muscle, she used to go to work, again tighten it, come back, again complain of the pain. So it was a continuous cyclic process. So what we started doing is we started giving her homeworks. So since it was an upper trap case, we started activating her rhomboids and lower traps and other stuff. And my fellow coach, Aman Mujib, also helped it in a very long way. So he made her do all the activations and all. I don't know where he's sitting. Acha, my coaches are, my team is clearly a last benches. So, so he did a very great job in addressing her pain, making her do all sort of, sorry?
No.
Okay. So he did a clear stage of intervention and bringing her properly into movements and activating the right muscles. And also when we were able to correct her, but it was very limited because it's a 3-hour class. And sorry, it was a 3-hour session in a week. So we were always used to start with initial activations and then followed by mobilization and then followed by strengthening, but it was only very limited what we were able to do. So we started giving her homeworks and exercises to do it for herself on the other 3 days off. And then that's when we were able to realize that, okay, this is how she'll be able to do things in a better way. And also here we also had a physio intervention as well. We collaborated with a physio just to be sure that we were on a right path so that we can provide the best service we can. And then it was also something which most of us forget, is that especially guys who go to gym, is the lower body. Like it's not always the upper body. We usually like love to look big, but it's the movement that we love to move or analyze. See, whenever you are in a gym, so it's always about lifting X weight and doing X repetitions, as I told. But when you get older, when you get into a normal public, like if I have to choose, if I have guys like you, 90% of you are general, regular public. Maybe 10% will be some fitness enthusiast or someone who is competing in a highest level. So the 90% of the crowd, they want to live in a way, let's say, I like playing badminton. I should be able to play it even when I'm 60 without any pain. So that's the motto. So movement without pain is something which is very important. That's the transformation we are looking for. So this is what, that's what Sunila's words about us. And then I'll just hand over it to Ashita from here.
So I think I would like to open the forum for questions. For these 3 cases, do you have any questions for us in terms of anything that you would like to ask us, whether it was Sunila's case or it was Shruti's case or it was even before that, Shweta's case?
In the first case, you have mentioned about the gait analysis you are doing for the back pain case, right? What type of gait analysis you do actually for analyzing the case?
Sorry?
In the first case, back pain case, you have mentioned about the gait analysis, right?
Yeah.
What type of gait analysis you use?
So basically, since she can't run, so we just see the how her pelvic shift is happening. Is there any pelvic shift?
How do you do? How do you do that?
So while she's walking, so whenever she's walking,
Okay.
so let's say if I have to put her on a treadmill,
Okay.
and if I have to view from the back side, like from the rear and like posterior side. So let's say she is having a internal rotation of the knee or external rotation of her foot, or there is a pelvic tilt to one side, or there is a shoulder drop to one side. So if there is a multiple challenges occurring at that point of time, which something we can't handle, that's when that's the reason. See, when I mean by rehab, it's not the rehab that all the doctors or the physios or the medical terminology use. Rehab in fitness world is, the R stands for risk assessment. If I see multiple challenges at that point, if there is a pelvic shift, too much of pelvic shift, if she is walking uncontrollably, I can't say that it's scoliosis, I'm going to do some manipulation and fix it, right? So I have to go to a doctor or consult a physio and say that, okay, this is something out of my reach. If there is a simple hip shift, hip tilt, that could be a case of her TFL is dominating too much. So I can ask her to do activation.
Not only TFL, it might be gluteus medius weakness also, right?
Yeah, that's what. TFL dominating gluteus medius is what I'm saying. So if that is one imbalance, just one of many imbalances, so what we can do is we can ask her to activate her glutes, maybe release the TFL, hands-on loosening, and then maybe activations, as I said, for the glute, and then slowly blending the movements by asking her to do single leg lunges or banded assisted lunges or something like that.
That's what my question is. How do you come to a conclusion? That's what.
So the answer to this is there is no one way. So we lack, when we do a typical strength and conditioning sessions, the apparatuses that you have, those devised apparatuses that you have with a physiotherapist, is not going to be available with a fitness coach to be able to address it.
That's what.
But
Because
yes,
you have mentioned people that you're using the gait analysis. That's what my question is.
So when he meant to say gait analysis, it is not like a traditional way of going through a gait analysis which you would do probably with those refined machines. It is not necessarily that. But what happens is that when you go through certain tests in the physical capacity, for example, when I do a reach test, I may not necessarily be able to tell you, am I 2 inches away or 1 inch away or 5 inches away, or am I crossing it by 2 inches? But the answer to this question is, yes, am I flexible? Can I even, if I'm probably stopping right here, my hamstring's not going to be able to take that kind of stretch. So therefore, to give you
You're talking
a
about the
simple
flexibility and extensibility of the muscle, right?
I'm giving you examples of various aspects of how we cannot do refined tests on machines, because these solutions are being done by a fitness coach in a strength and conditioning environment and not by a physiotherapist in a setup where you have those refined machineries to be able to address it. Does that answer you partly? We will not be able to use the exact gait test that if you're a physiotherapist per se or you visited one, will be able to do it. Nonetheless, we will have 5 different methods to identify if the musculature of that particular activity is activated also or not. For example, if the hip shift is going to be happening, then clearly it could be a result of a whole kinetic chain of functions which is going to take place. So then what will we do? We will have to test how is the glute functioning in isolation? How is the quad functioning in isolation? How is the hamstring in isolation? Is there a lower back activation at all happening or not? Is there a thoracic spine mobility established or not? So it's not one quick solution, one activity which is going to lead you to it, especially in a strength and conditioning environment where we do not have refined machines. Also, one is we do not have refined machines. Are we physiotherapists? The answer is no, we are not. We have not studied the science of physiotherapy. We studied the science then of strength and conditioning, where we know that the muscles can get activated and when they're not activated. And if one muscle is overused versus the other, the adoption of methods for solutions could be unilateral training, just finding activation of that particular muscle, finding more solutions around it, increasing mobility, resisted mobility, and then probably moving on with slightly body weight load and sometimes just adding isometrics. And there can be so many other ways too. But then all of this is post we've done various levels of checks on it. Does that answer?
Yeah, thank you.
Thank you. More questions invited. I really like you grilling us for it. Thank you.
Thank you, Subbu. We are actually running out with short of time. Now we'll start with inauguration.
All right. Thank you.
Good afternoon and welcome all the delegates. It's been a wonderful afternoon and it's been a great presentation from Team Tonabolics. I would like to invite our team, Dr. Rammohan Reddy, Dr. Deeptinandan sir, Dr. Nitish Ban on the stage for lamp lighting, and our director, Dr. Pavan Gorukanti garu. So Dr. Pavan Gorukanti garu is a director and he's a doctor by profession. He's a pulmonologist. He's an alumni of Osmania and Manipal, and he's been here and then later on moved to the US for his higher education. He was later working as professor there at the Michigan State University Hospital. And yeah. Dr. Kiravani garu, I request you, Mr. Kiravani garu, please come on stage.
Mr. Maxwell, Aruna. I also invite Aruna and Mr. Maxwell, who is a legend in cycling circuits. Please do come on stage, sir.
I'd like to invite Dr. Pavan Gorukanti garu and grace the occasion with some kind words.
Thanks, Amit, and thanks all the ortho team, Dr. Ramon Reddy Garu and Kiravani Garu, and all the legends here in the front rows. And more importantly, thanks for all of you to come. First time I'm seeing this hall full, like we can say house full. When I walked in, I thought, was it like some movie like Jawan going on? No, maybe something better is going on. So great, and you know, you're like involved in this ones too. But these kind of sessions are great. You know, usually we go to our doctor conferences. Mostly it's technical discussion, mostly doctor kind of thing and all. But this is a unique thing. Yeah, now we have some are patients. Some are just bystanders, some want to improve fitness, some are professional athletes, some are physiotherapists, some are trainers, some are doctors and all. But you know, this kind of multidisciplinary approach and all getting all them in one one stage will be great. You know, sometimes there may be a little disagreements between specialties, between doctors and between physio, between doctors and something else and all. But you know, overall for a patient, I think it works best if all combination is good. So it's great that you have attended this, and you know, fitness is like really important, and fixing it is one thing, but prevention is always better than cure. So you know, you try to make use of this time to ask any kind of questions you have from any kind of people also. Both diet and exercise is beneficial for healthy life. I myself, being a doctor also, generally it says that you're supposed to have a heavy breakfast and then little less lunch and dinner is least. But I do skip breakfast and lunch. I only eat dinner. So, it can be done multiple kind of ways, but as long as the calories are accounted, exercise too, there's a lot of science and literature between that. It's not a straightforward thing like what exactly to do is still like hundreds of papers are there and a lot of depth of research is required on what exactly which prescribing, and this keeps changing also. So that's great. A combination of diet and exercise, definitely. I mean, in Netflix recently, in this last month, one thing was coming, living to 100 plus, like 100 plus years. Do you know which countries live 100 plus year? Highest number of centenarians? Yes, Okinawa in Japan, and then like blue zones. Yes, Loma Linda, California, and then Greece and Italy, Sardinia, and all, because that's like a really good thing. But it definitely needs a combination of diet and physical activity. There is no substitute for that. And then stress reduction and other things. I don't want to take your time in this August audience, like all are experts in their field, but make use of this session to interact more now and during later on after we finish the academic things. Everybody, including Dr. Ramon, Dr. Deeptinandan, all of our ortho doctors, everybody is more than willing to answer any kind of questions. So please make this opportunity to connect more and make a commitment for your health. Though in the day-to-day life, everything is important, but health is the most important, I'll say, but still we'll try to give only very, very little time. Many times I hear that you're too busy working and all. I can say that you're never too busy, like only if you are in the absolute hospital in ICU and all, then you'll know what exactly is really important for us, and health is important. Please do concentrate on that and make use of this session to upgrade your health. Thank you. Yeah.
I request Anand Kiravani garu to please come on to the stage. I request Anand Kiravani garu to please come on the stage and receive the memento from Dr. Pawan.
A very good afternoon to all. ACL is one of the most important ligaments in the knee joint. It helps us to be steady and stable while doing our activities like walking and doing various sports. ACL tear can cause significant instability, damage to the joint cartilage and meniscus, resulting in arthritis in the long term. Treatment of ACL tear involves surgery, physiotherapy, fitness with rehab program so that we can get back to normal life again. I invite to Dr. Rammohan Reddy Venturla to give his presentation on the subject. Kindly feel free to interrupt and ask any questions during this presentation. Thank you.
అక్కడ నిలబడాల్సిన అవసరం లేదు. ఓకే. Yeah, thank you, Khaja, for that nice introduction and calling me on stage. Now, Ashrita, thanks a lot for treating those patients. I sent them to you because I was convinced that your program works. It worked for me. It was only after 6 months of training that I decided I can help them more. When my treatment reached an end point, when my physiotherapy sessions were not able to take it forward for her, especially Shruti. She was wheelchair bound for 2.5 years, and after 3 to 4 months of rehab program, she is walking. She has gone to the restaurant for the first time in her life after the major injury. That was a great result. I myself have benefited from the rehab program of TONABOLICs, and there are 2 trainers in your team, Sapna and Tarun. They really killed me during the other sessions, and I like it. Right. Now, anterior cruciate ligament. How many in the audience have got anterior cruciate ligament injuries? Just, yeah. Now, how many of you have really gone through and understood how the ligament looks like? Googling. Few. Now, the reason why I am saying is this morning I saw a patient who had ACL and PCL surgery done 2 weeks ago. It took me around 3.5 hours. After the sutures were removed, she comes to my clinic, says, "Doc, where was the surgery done? I am having pain here. Is there where the ACL was?" And I was thinking, she's an educated person working in IT. Was my counseling correct? Did I treat her properly? That is a level of awareness. Despite counseling, despite educating, things still go wrong. There are many who go for unsupervised training alone in the gym or many fitness units and all. In the next few slides and videos, you will see how that can be damaging. Now, what is ACL? Sorry. It's a small structure, 3 centimeters in length. It attaches the top of the thigh bone behind to the leg bone in the front. What does it do? It gives you stability while you are walking, while you are running, while walking up and down the stairs, while doing your sports. It's a small structure of 1.8 centimeters in diameter, but it protects you from arthritis. And that is how it looks like. See the thread structure? And the MRI shows an intact ligament. And this is an intraoperative arthroscopic picture showing the footprint of the ACL on the tibia, the leg bone, and the thigh bone at the top. How do these injuries happen? Most of them think that it happens with major road traffic accidents, with sports. No. It can happen with simple trip on the stairs, 1 or 2 steps. As I said before, unsupervised training. You go alone to the gym, you want to do weightlifting, deadlifts. A small twist is enough to cause tear of the ACL. Look at this picture. At the top is a normal ACL ligament, and it is shredded to bits in the picture below. We think we are very strong. Unfortunately, no, we are very fragile. 1 split second is enough to cause this damage. Most of the patients who come to me, they come after 5, 6, 7 months after the initial injury. Why? Because they think it's a small sprain. Now, what are the symptoms after the ACL tear? ACL, once it is torn, it bleeds, which means that joint will be swollen. In the first few days, the ligament can get stuck between the 2 bones and can cause locking. Suddenly, that joint gets jammed, and slowly that locking goes off. What's more important is the thigh muscles get wasted. It becomes thinner in diameter. As I said before, ACL is very important for stability. Then you start feeling unstable, especially while doing sports or walking up and down the stairs, changing in direction, and you start losing confidence while doing even normal activities. These are the main symptoms of ACL tear. Remember this. So, when an injury happens, get an assessment done. Now, how do we assess in the clinic. It's a very simple and straightforward test, anterior drawers. Anybody can do. A doctor doesn't necessarily has to do it. Look at the knee joint. The leg bone is so unstable coming forward, 2 to 3 centimeters forward. That should not happen. That's a simple test which one can do after an injury. Initial few days it might be painful, but later on, once the muscles get wasted, the instability gets much more profound. Yeah. This is another case, as I said before in the morning, I saw this patient after surgery. She had both anterior and posterior cruciate ligament tears. 4 to 5 centimeters of translation in the sagittal plane. She could not move her leg properly without being afraid. That's how devastating a ligament injury can be. How do we confirm? Of course, anterior cruciate ligament injuries can cause instability, but also muscle wasting without ligament injury can also cause instability. So we have to prove it. That is a normal ACL. There is no ACL here. It is torn from the femur, and that's how it looks like when it is torn. This is a normal ACL. One of the main questions that is asked by the patients is surgery needed? Why do I need to get surgery done? It's important to get surgery done if there are signs of instability, if you are not able to play sports with confidence. It is also important to get surgery done to prevent arthritis. The short-term gains are stability and sports. The long-term gain is to delay arthritis. The literature, when you review it, it says you do physiotherapy properly, then you don't need surgery. But the more I see the cases, I am more convinced that these ligaments need surgery. And you will see in the next slide why. Look at these arthroscopic pictures. This is a patch of arthritis in an anterior cruciate ligament deficiency which was neglected for 4 years. The joint is arthritic already. Another picture where it is grade 2 arthritis, and look at this tibia, the surface. This is normal cartilage, patches fully grade 4. The subchondral bone is exposed. We now have enough evidence to show that 50% of the knees with ACL deficiency can result in arthritis within 15 years. So if somebody is 18, by the age of 40, he might need knee replacement. That's how bad it can be. The question is, will surgery help to delay arthritis? The evidence so far says it delays, but it does not completely stop arthritis. This you have to keep in mind. What do we do? ACL once torn, we cannot repair it. We cannot take the broken fragments and stitch together. No repair. That is a torn ACL. We have to take out the broken bits, freshen it up, and then there are two types of grafts which I use in my practice. One is a hamstrings and one is a BTB graft, which I will show you in the next couple of slides. The patients, they come to and ask me, what kind of graft are you using? There are many kinds of grafts. These are the two grafts which I discuss with my patients, counsel them properly. Let's come to hamstrings. Hamstrings are at the back of the thigh, not on the front of the thigh. There are 4 hamstrings. We take 2 of them, semitendinosus and gracilis. Hamstrings graft, the incisions are smaller. They are mainly meant for routine, amateur, non-professional patients. They are slightly weaker than the bone tendon bone graft, and the recovery is longer. When patients ask what's the duration, I say 9 to 12 months. It takes as long as that for the graft to integrate with the bone. This is how I do my hamstrings graft reconstruction. That's a torn ACL. Take 2 strands. That's how it looks like when we take them out. process them, convert into 4 strands and fix it inside. The graft never looks as normal as the original native ligament. It is artificial fixation, it is to give simple stability, but it is never going to be as normal as the original one. Keep that in mind. Here is a small video, brilliant edited by my colleague Karima. Just 40 seconds. That is a torn ACL stuck in the joint. Slowly, yes. Yeah, now. Show towards the tunnel, upar. Show towards the tunnel, upar. Upar, yeah. Yeah, pull, slowly. Yeah, now. Very good. So that's how the hamstring graft is inserted into the joint. What's BTB? This is the original traditional way of doing it for the last 40-50 years. We take the graft from the front of the knee, that's a kneecap, the central 1/3 of the patellar tendon and the leg bone, which is the tibia. The incision is bigger, it looks very big, but the graft is much stronger than the hamstrings. The healing is good and quicker than the hamstrings because it has got bone plugs on either side of the graft. It is meant for top elite athletes who do weight bearing, torque movements like gymnastics, volleyball, basketball players. You can see the ACL which is torn, that is the incision for graft. We mark it, take it out, process it and fix it into the joint. That is a graft, BTB graft in place. A 30-second video of how the BTB graft is. Just for 10 seconds is enough. Okay? That's fine. So that's a BTB graft. Now these are the two grafts in place. The left one is a hamstrings and the right side is a BTB graft. My job is done. But the actual work starts now. At the end of the procedure, I have to make sure that the graft is stable. And you can see I make my checks, and that's a negative anterior drugs test at the end of the movement. Right? If you remember the first slide where it was coming 3-4 centimeters anteriorly, the leg bone, now it is stable. There is no more movement. The work starts now for the patient. Physiotherapy. Most of the times we get frustrated in the clinic because patient comes after surgery 10 days and after that it is 2 weeks, sometimes 6 months, sometimes 12 months. They come back and say it is swollen, it is stiff. They have to understand that the journey of recovery is very long, 9 to 12 months, sometimes it is up to 18 months. Unless the physiotherapy sessions are done properly, the recovery is never complete. I called Dr. Sumant, who is the HOD of physiotherapy of Yashoda Group of Hospitals. Dr. Sumant. All right, Prem. Right. Prem is one of our leading physiotherapists in this hospital. He will explain in a couple of minutes how physiotherapy is done and why it is important for the patients to follow up week after week after week. Every week the physiotherapy sessions change. You can just explain. Okay, Rani. Okay, that's fine. Dr. Sumant is on his way. He is just outside. Once the physiotherapy is done, is it complete? The physiotherapy team looks at the diseased joint, at the operated part, and to a certain extent other parts of the body. But is that enough to reach the top level sport? The answer is no. There is a lot more to it. Musculoskeletal conditioning and rehab program after ACL reconstruction and physiotherapy is a must if one wants to get back to elite sports. I got two patients. One patient did his ACL reconstruction with me. 4 months later, he tries to climb a tree 3 feet. Simple twist, the ACL goes off again. Another patient, 6 months post surgery, does kickboxing. No weight bearing, no twisting, nothing. In the air, the ACL goes off. Now I will show why muscle conditioning is important and how it is done. This is Aruna, one of our international gymnasts who has brought so many laurels to our country. Look at her.
Go squat. Up.
That's a single leg hop test. It's her right knee. Unless you test it, don't go back to sports. It's very, very important to do all these tests before one decides whether they are ready to go back to sports or not. I would like to invite Aruna on stage. As I said before, she is an international gymnast who has undergone multiple surgeries. She knows the journey of physiotherapy, rehabilitation. She would like to talk to you how her journey took her to foreign countries for training, which was probably not available in this country. She wanted to get back to elite sports. And she has done this after 2 surgeries. It's not easy. Aruna and Manoj Rana, her national coach, I would like to welcome them on stage and share your experiences. Okay, just explain why you wanted to, right? Okay, your stage.
No. Good afternoon, everyone. So, first of all, I'm very much thankful to my doctors and my physiotherapy team, Ramon Reddy sir, DN sir, Sridhar sir, and Prem sir, because I've been in touch with them since 2014. In 2014, I was diagnosed with shoulder injury. That is when I met DN sir first, and he made me approach to Sridhar sir. So basically, when first I went to Care Hospital because I'm an elite sports person, gymnast, and we have multiple directional movements. It may be bar, or it may be floor, beam, and everything. So it was so serious that I was unable to hang on bar, and it was getting very difficult for me to train. So I was in Asian Games in 2014 in Incheon, where I felt now further on to continue my sport, it is very important for me to meet doctors, consult, and see what has to be the next step taken care of. And then when I've already met one doctor in Delhi. He said, no, you have to go through the surgery. And then I came back to Hyderabad. Then I met the other doctor in Care Hospital. He said, yes, you are indeed required to get surgery done. And then I came to meet DN sir. He said, maybe you don't need surgery. Let's start working with physiotherapy first. And then let's see what happens next. If you can recover with physiotherapy, you're good to go without surgery. And then I met Sridhar sir. We worked 6 months with the shoulder rehab. That was labrum tear. And then it really worked well. Without surgery, I can come back to my sport. And till today, I have no issue with my shoulder. So that is how my injury journey has started. And then in 2018, post my World Cup medal, that was the first medal for India in gymnastics. I was preparing myself for 2020 Olympics. So 2018, November, I had my qualification competition in court bus. So I was well prepared, and I know that this time I'll be there in Olympics to win a medal for India. So unfortunately, on day of the competition, I was attempting a difficulty vault wherein, due to the incomplete twist, I've torn my ACL. So I had no other doctors or no other question in my mind. It was just my doctors who I've met earlier, Continental Hospital, Hyderabad, Ramon sir and DN sir. So I came directly from there, consulting my physiotherapist, Sridhar sir. And once I was here, they said, Aruna, you have to go through surgery because your ACL is completely torn. And then me and my coach, we don't know what to do because we had a target of Olympics, but we are just running out of time because only 9 months were left for the last qualification system. So we know that if we don't get the surgery done and get back between 9 months, it would be very difficult to complete my dream. And then first stage was to completing the surgery. We did it. The first surgery was the hamstring graft taken. And then the next question was, will I be ready in the next 8 months to come back to the world platform? Anyways, my coach, he was ready to get me back. Even I was ready, okay, I'll take the risk. But the other point, I've never seen such doctors who can push athletes to the next level saying, no, Aruna, you can go forward. We are anyways there, back of you, to help you in all the ways we can. So that is when doctors, they stand back strong with me saying, yes, go ahead. So within 6 months, I was back to my sport. And I was into the Indian team post-selections in September. And I made it to the Indian team, and I was there in World Championship, aiming high to get the Olympic quota. And unfortunately, again, just day before the competition, it was just in hyperextension. And again, I have torn my ACL. So it was just the day before competition. So that is when, post coming back from then, even though me and my coach, we were like, we can't miss Olympics. So what is the next competition from where we can achieve the quota? But meanwhile, what we have analyzed through my whole process of rehab was, post my first ACL, we were very much keen to come back to the sport, as sir said, return to the sport, and get back to the World Championship platform because of the Olympic qualification. But we have somewhere neglected our SNC part. Surgery was done successfully. Physiotherapy was completely going on for 6-7 months without break, 3 sessions a day. Everything was fine. But what about the SNC part? That is when, post the second surgery, we could see that SNC plays a very vital role in elite athletes, rehabilitation. As sir said, 20%, post my experience of after 4 surgeries, I could say that 20% if the surgery is done, next 20% if it is about the physiotherapy, and the next 60%, the major role is SNC. That is what helps an athlete to come back to the sport. So post 2019 surgery again, it was BTB graft which was taken, and we were again sure, okay, 2020 was done. I couldn't go compete back. So what next? 2024. Before that, World Championship, qualification system, before that, Commonwealth Games. So that was the next goal. Everything was planned backdoor from top to bottom. And we have started emphasizing post-surgery, and that was the lockdown time. So physiotherapy was going on through online. Everything was going on. And then we started post 6 months, we started emphasizing more on SNC, building muscles, all the major groups which are important to hold the hamstring graft and everything, BTB graft, whole part of ACL. And I was completely back within 1.5 years to the sport. And wherein you have seen the video, that was my post 2 ACLs, that was Egypt, where I won 2 gold medals again. So that is when we've realized, okay, weight training is very important. But again, weight training, at that point of time, I was focusing on building up my muscles, which can help me to give more strength rather than taking full load onto the bones, but muscles can hold it back. So we were mostly focusing on hypertrophy, building it. And again, we didn't realize that somewhere, some things we are neglecting, because building the muscles, and we left out physiotherapy again. Okay, physiotherapy is done. Now I think we need to focus on muscles more. But post that, again, I was ready for the next Olympic qualification in 2022. That competition was in 2021 in Egypt. And 2022, it was a Cairo World Cup, where I was there. I finished my first apparator. I got qualified into the finals. And the second apparator was the next day. And in the second line, when I was doing my twisting, it was again incomplete due to an incomplete twist. I again torn my ACL. And then what next? So me and my coach, we have actually taken a board, and then we started writing what was the actual things which got neglected since my first ACL 2018 till date, which we have to focus now, because the third ACL is the last hope I have to come back. I'm ready to get surgery done, but what next? Post-surgery, surgery is not such a, for a patient, surgery is nothing. We can get through the surgery, but what next? Post-surgery, how we deal with the injuries, how we deal to come out of that emotional trauma is actually what is very important. And then we have completely planned, okay, this is how it has to happen. And then we focus saying, for an elite athlete and being a gymnast, for us it is very important to have a sport-specific physiotherapist and SNC, which was lacking in my previous surgeries. Yes, I had physiotherapist. Yes, I had SNC. First surgery was completely physiotherapy. Second surgery was completely SNC. But it was standard SNC and physiotherapist. So then we thought, being a last chance, we have to give 100% whatever we can. And then we went to Israel post-surgery. I mean, surgery happened. So post-surgery, 20 days post-surgery, I flew to Israel to Natalie Battler. She is in gymnastics. She herself is a gymnast. She actually retired as a player because when she was playing, she was into the European Championship team. But she had to retire because of her injury. And she felt that there was no one who could help her to come back to the sport. And that is what which triggered her to become a physiotherapist and help especially gymnastics. So we very well know about her, about ma'am's background. And my foreign coach, Andre Levitzer, suggested, yes, I think this is the time where you have to meet the actual gymnastics physiotherapists first. So I went there. She started, aligning all the parts, biomechanics. I'm not so specific about the scientific things. So she started releasing the scars to make the movement easy, developing the range of motion, the flexion and the extension. Because I have hyperextension on my left, but due to multiple surgeries, I don't have hyperextension on my right. So she was most emphasizing on that to get the range very quicker so that I can start focusing on the strength, so that I can have that end range of strength. And then I was there for 2 months. She helped me get back my range of motion, and physiotherapy part was done with the next 2 months. So the next 2.5 months I was back, and I started going to the Gopichand Sir's Academy, where Ganesh Sir, he's an SNC expert, who also trains the current double champions. So he started helping me with the weight training and all. So he gradually increased it with the body weight, and now where I am today, it's been 8 months post my surgery, and now I'm back to my gymnastics, actual training, and hoping to participate in December back. So this is my journey.
Thank you. Aruna, thanks a lot. She's an inspiration to many. When I tell her, why are you putting your body through so much damage? Injury, surgery, injury, surgery, injury, surgery. She says one line, "Okate jinnagi undi sir. I'll give it my best shot." That's who she is. Right? You don't find many people like that, you know. She wants to be there at the summit. She's ready to do anything for that. Thank you, Aruna. So, to summarize, ACL ligament injuries are very devastating. They have to be recognized early. So, if you get injuries, get your assessments done. Have a detailed discussion with your doctors, whoever it is. Get it confirmed. Then make a decision whether you need surgery or not. If the surgery is done, then be ready for 12 to 18 months of proper training. Don't jump into getting back to normal activities into sports unless you pass the fitness tests. You have seen Aruna's experience. It can cause damage to the graft that is already put in. As a surgeon, I do my work, but then the process starts of recovery, which is much longer. If there are any questions in the audience, I'm quite happy to take them. Dr. Sumant will talk about the physiotherapy as well. Please feel free. This is an interactive session. It's not one-sided lecture at all. Anyone?
Thank you for the presentation. I think all of these things are very insightful. I have went through the ACL surgery myself about 4 to 5 years back.
Yeah.
And although I went through the rehab and the physiotherapy about for 12 months, and I am back in the normal sports right now. I've been playing sports like tennis, badminton, table tennis.
Yeah.
But I want to understand that in the long term, what are the things that we can do to kind of have the strength in the muscle, and so that we do not get the ACL tear again? Is there a relevance of other supporting muscles like hamstrings, quads, to support for these exercises or not?
That's very important. And now, when you take the hamstring graft, you are making your hamstring muscles weaker by 50%, which means you have to strengthen your hamstrings much more than the quadriceps. That's number one rule, all right? And as I said before, to prevent further injuries, you have to train for improving your reflexes of your foot and ankle, the speed, the agility. It is not, don't just look at the knee joint. You have to look at conditioning so that when there is, in a split second, you can damage your knee joint again. So that split second, you should be able to protect your graft. That's where the conditioning and rehab program comes into the picture. Physiotherapy has got certain amount of work to do for the joint, but beyond that, there's a lot more.
So, sir, are you suggesting that still after 4 or 5 months, I can go and take this conditioning?
Absolutely.
Okay.
There is no doubt about it. Yeah.
So the normal exercises in the gym and everything would not be like
They
that?
are not enough. They are not enough.
Not enough.
I have realized that. I train, as I said, I train with tonabolics, and I realize how different it is. I know my anatomy, I know my orthopedic surgery, but the way the training is, it is totally different. It takes your endurance levels, your strength levels to a much, much higher level.
Sure. Thank you so much, sir. Thank you.
Anyone else? Any queries, questions?
As a follow-up to that question, so do you suggest that you need to continue with all the aspects of it, physiotherapy, strength and conditioning, once you do your, post-surgery?
Absolutely. Post-surgery, there is a regime to prevent failures of the graft. There are many regimes. You can look on the Google. One of them is San Antonio's ACL physio and rehab regime. It's very easy. You can follow it on your own. Right? The minute you stop training, the muscles start getting wasted. As I said, it is not a normal ligament. It is a graft. The proprioceptive fibers in the graft are not there. So it is very important that you strengthen your muscles on the outside, and it's a lifelong process.
Right. So if there's a partial tear, would you still suggest basis the examination that you go in for?
Absolutely. My personal opinion, there is nothing like a partial tear. You got anteromedial and posterolateral bundles. Even if one bundle is gone, the other will get affected because the insertion is a continuity. Half of it will not work. So when the patient says, I don't have confidence, I feel unstable, even if the report says it is partial tear, I make my assessment. Sometimes I do diagnostic arthroscopy, make sure that the ligament is not functioning, and then I go ahead with the reconstruction.
Thank you, doctor.
Right.
So, good afternoon, sir. Sir, actually I've started my training of tennis, athletics and football. So, are there any ideas that how I can take care of my body while playing?
Physiotherapy and rehab program. You are doing 3 different things. So you need to train your body in 3 different ways. Every sport is different. A proper assessment is important before you go to top elite sports.
Okay, sir.
All right?
Okay, sir.
Sir, so just to add to it, so are there any specific tests he should undergo before going for the training and all?
Absolutely.
Okay.
Gait analysis,
Okay.
core strength, are there any stiffness of the joints,
Okay.
and then your medical checks, very important.
Okay. Okay, sir. Thank you. Thank you.
Ram Garu, I myself I am a patient of chronic lower back pain and knee pains. So just like you have changed the name of a patient into Shruti to protect her privacy, so I share my experience with the 2 experts I have met. I'm changing the names. So a very famous orthopedic Dr. Dharmendra, I changed the name, he asked me to give rest to my knees and lower back for life. For example, he advised me not to use the staircase and not to lift any weights, etc., etc. So on the contrary, when I met this lady, very competent Pilates lady, Hema Malini, I changed the name again. So she said, what nonsense. The orthopedic doctors, they claim that they know everything, but I'm sorry, I don't accept. You have to use your muscles. You have to train them to get back to normalcy. So with due respect to their experience in their respective fields, I'm confused to travel with whom. I'm seeking your 3rd advice, not 2nd advice from you. Thank you.
Sir, you are a legend, sir. I am seeing you in person. Yeah, I can tell you a bit about back pain and knee. What you got, the information and advice from the second person is correct. You don't have to necessarily be a doctor to advise. 3 years ago, I had a very small disc problem. Surgery was not needed. But my spine surgeon said, you have to stop doing cycling. You can't do any more activities. You have to be careful. You have to protect your back. But today, I can lift 50 kilos after the training with TONABOLICs. I can do bench presses, right? What is important is an assessment by a proper trainer. Those who use evidence-based science. Every time the coaches come, Tarun, Sapna, Aman, Dheeraj, the first thing they ask is your body okay today? Have you had proper sleep? Is there any stiffness in any part of the body? Based on that, they will schedule the program for that day. Now, sometimes I get only 3 hours sleep, 4 hours sleep. They know that I cannot do full fitness program for that day. So it does not matter whether you have got a chronic back pain or disc prolapse or arthritis, but muscle conditioning, strengthening is very important. One should not take rest. The minute you take complete rest, your muscles start getting wasted, your bones will get osteoporotic. The body has to be in motion all the time, all the time. And that's what Ashrita and her team did with Shruti. 3 years in wheelchair, she had lost complete hope. I didn't know what to do. All I can give is painkillers. The physio can look only at her ankle. I did the surgery. But it's beyond that. That's where the training, the rehab experts, it is not physical training. They do talk to you. That's a psychological boost. It's always positive. If you look at some of the physiotherapy sessions, this is not good, this is not good, this is not good. No. The rehab program is completely different. You are doing so well today. I know sometimes they just want to boost my confidence. Fantastic. After 1 hour training, I know I have not done properly that day, but you go back to work with a positive frame of mind, and that's what is needed. Rest is bad. It should not be done.
Thank you, doctor.
Thanks, Yavani.
Doctor, nowadays a lot of chiropractic treatments and osteopathy treatments are getting famous in
Right.
India also. What is your take on that?
There are some very good chiropractors. I don't know many. It's a big professional network in the Western countries. I feel it is part of rehab program. As long as it is done properly, there is no issue. But going to quacks, untrained professionals, then you can cause more damage to your body. Yes. Sudden twisting of the neck can cause injuries to your carotid vessels. Patients have died. Not patients, people have died while undergoing those sessions. Yes. All right.
Good afternoon, sir. Good afternoon, everyone. As you said that ACL construction or hamstring graft leads to the 50% wastage of the hamstring muscle. Coming to the Aruna ma'am case, she went to the 3 ACL reconstruction.
Yes.
Then what is the condition of her hamstrings right now?
Yeah.
And did she went with the same hamstring graft technique for the 3 ACL reconstructions?
Okay. If you look at my presentation, for elite athletes, I use BTB. But in her case, I had to use hamstrings because I felt the patellar tendon was too thin. Everything went very well. Okay. Once you take hamstrings, it does not grow again. So you can't take hamstrings again from the same side. The second was BTB graft, which was good. She got her medals, fine. But the third time, there is no BTB, there is no hamstrings on that side. Then you have to take it from the opposite side. And I told her, I refused, saying there is more damage to your body. Then what you do? You do allografts, you take it from cadaveric and then do them. All right. So you can take quadriceps tendon, you can take peroneal tendons, but they are not good. They can cause damage. All right. Anyone else?
You said earlier that you stopped believing in rehabilitation for ACL injuries. So could you explain why you stopped believing in this method and how you assess whether an ACL injury requires a full operation or physiotherapy will be enough?
That's good. The more I look into it, I feel surgery is more important. The assessment starts in the clinic. Simple tests, is it unstable, but the patient is asymptomatic, still needs surgery to prevent arthritis in the future. Is a person very sedentary, home, car, office, back home, then they might not need surgery. So assessments are very important, and then you decide whether they just need physiotherapy or rehab program. If the person says, I'm not interested in playing sports, I just want a bit of normal walking, then a bit of physiotherapy is enough. We don't need to operate. But I tell them that you are risking your knee. In the long term, you risk getting arthritis. That's when they have to make a decision whether they need surgery or not.
Sir, excuse me, sir. This side, sir.
Yeah.
For endurance and strength, you are referring tonabolic.
Yeah.
And for food and nutrition, what you suggest and whom you prefer?
There are professionals. Ms. Ashita, she is very good with nutrition as well. but you need to do your own research and find the right professionals to do that. Okay? Right. If there are any more queries, I'm quite happy to take them on my phone or through mail, or my colleagues are there to, to take your numbers and address your concerns. This program is meant for that, to clear all your doubts. Thank you.
Dr. D.N. Reddy is our second speaker today. From knee to the shoulder now. Rotator cuff injuries are common in young due to major accidents and in the elderly due to minor trauma. These injuries are often ignored and neglected. Surgical repair for complete tears essential for restoring in normal shoulder function and return to sports. Delay in the treatment of rotator cuff muscle tear can lead to rotator cuff arthropathy, which will need shoulder replacement. Dr. D.N. Reddy is an expert and authority in the management of rotator cuff tears. I invite to Dr. Deepti Nandan Reddy to present his lecture and share his expertise and opinion in the management of rotator cuff injuries, importance of physiotherapy and rehabilitation program.
So have any of you heard about rotator cuffs? Rotator cuff? Yeah. Am I audible now? Has anyone heard about rotator cuffs? What is a rotator cuff? How it works? How it helps in the shoulder? No? Okay. So we will start off with the basics of how the shoulder works, and then we will go ahead with the repairing and how you assess them and everything else. Now, rotator cuff is one of the most important structure in the shoulder itself. The shoulder is a complex joint, and people always worry about shoulder. They think shoulder is a difficult thing to do. If you do surgeries on the shoulder, they don't improve. There are all the myths which are available at the moment in the general public's opinion. But most of the time, it's a very straightforward condition to diagnose and a very straightforward condition to treat if it is diagnosed correctly and treated at the right time. So the shoulder is held by all those muscles, that is the rotator cuff. So there are 4 muscles in the shoulder, which is the supraspinatus is the name, the one which is on the top, infraspinatus at the back, teres minor at the back again, and one in the front is called the subscapularis. So why is it important? If you see in the top picture there, the subscapularis is pulling the head into the socket, the infraspinatus is pulling the head into the socket. So these are holding the ball into the socket of the shoulder. The reason shoulder is complex is because that socket itself is not fixed on the body. It is on the shoulder blade, and the shoulder blade moves on your chest wall all the time. So if the chest wall, if the shoulder blade is not stable, your rotator cuff will not be optimally functioning and your shoulder will not function correctly. So we will get to know why we should look at the shoulder blade also in addition to the shoulder itself. So if there is a tear in the rotator cuff, when you lift your hand up, the rotator cuff should hold the ball onto the socket so that the deltoid can pull the arm up. But if the rotator cuff is not there, it is not holding the ball on the socket. So the whole head starts moving upwards and it starts hitting the bone on the top, which is called the acromion, and that is where you get the pain. So it's not a single point of attachment of the rotator cuff, it's a very broad attachment. So just a slide to show the anatomy of that. And most of the time if I see a patient coming into my clinic, depending on how their hair looks, I can tell you what condition they have. If they are young, no white hair, unlikely that you will have a rotator cuff tear. And if somebody below 40 comes and tells me that I have a rotator cuff problem, then I know the diagnosis is wrong straight away, because it is not a tear of the rotator cuff below 40. I have been in practice for nearly 28 years. I have not seen a rotator cuff tear below 30 years of age. If you have gray hair, then your tendon start degenerating, the function start changing, then you might get a tear. Older gentlemen also can have it, because the tendon quality changes as we age, like we get gray hair. So why is it important? Because you get pain and weakness of the arm, and many a times they are not even able to lift their arm up. Now, how do you differentiate if somebody has a tear or if it is a stiff shoulder? Simple thing, hold the hand and lift it up. If it is lifting, the joint is okay, but the motor which is lifting the ball is not working. Means there is either a nerve injury or the tendon is cut. So it's a very simple way of looking at it. So who is mostly affected? As I said, over 40. Overhead sports and overhead activities can cause a problem. We will talk about it next, because if you look at the shoulder, see, those are the 4 muscles which are holding it down. Now, if you keep doing overhead activities, that keeps pinching on the bone on the top, and that repeated rubbing will tear the tendon. Like you wear socks, you get a hole in the sock after wearing for some time. That is the friction causing it. So that is one mechanism, and sometimes the blood supply to that is not good, that is why they tear. Sometimes you get degenerative tears without any pain also. That is because people have a different way of their anatomy in the rotator cuff, which is compensating for that problem. So how does it tear? If you have a fall, already weak tendon is there, you have a fall or a pull, it will tear and you will get a tear of the tendon. Sometimes without a fall also you can get a tear. So how do you diagnose them? Most of the time clinical assessment. If you see that gentleman, as I told you, he is not able to lift his hand up, but as he holds it, he is able to lift it up easily. And the arm drops. So how do we assess? This is how I assess them. You can see that side is weaker, and as he lifts the arm up, that is not holding, it is dropping. So the motor which is holding the arm is not working. So why do we investigate further? Now I know the diagnosis. Why do I have to get another scan and everything else done? You know, on an X-ray you see a bone, but you don't see the muscle. So how do you see the muscle? You get an MRI scan. This particular MRI, you see the tendon is completely intact, that black structure which is above the ball of the shoulder. But this lady we operated yesterday, she had a tear of the tendon, pulled off the bone, so there is no continuity. All the white there is the defect in the tendon. So that is why that shoulder was not working. And they have pain at night, they can't sleep well, they can't lift their arm up. Every time they move the arm above the shoulder, they have pain. And repairability means, can this be repaired or not? Cannot be assessed on an MRI scan. That I have to do only surgically. If you leave the tendon like that, what happens? If you see the top A column there, the muscle is full, there is no fat. White is the fat in there. As you go along, the fat increases, the muscle reduces. That means the muscle becomes smaller in size. So if you get a tear in the tendon, you go to some doctor and they will say, give an injection, painkillers, you are fine, because from outside you don't say anything. You control your pain, you start doing your activities, you think I am fine, I don't have a problem. But if you don't test that particular muscle, you will miss the diagnosis. And you will come to me 1-2 years down the line saying, now repair my tendon. I can't, because the size of the tendon is reduced, the muscle is reduced. As was discussed earlier, if you don't use a muscle, it becomes smaller. If the muscle is cut, there are mechanisms in the body which makes it convert from muscle to fat. So you should reattach the tendon to make it work correctly. So natural history, these are the papers. So scientific evidence is there for it. So if you leave it, they all increase in size, the tear. If you have a torn cloth, if you pull it, what happens? It tears further. So if you darn it, it will not tear. So fix it, so it doesn't tear further. If you look at tear progression over 8.6 years, they all progress. They all become bigger and they all become more problematic, and most of them become non-repairable. And if you look at the healing also, if you leave them longer, they don't heal well, they don't function well. So identify them early and fix them early. That's the key. So what happens if you leave it like that? See, if you that X-ray, the ball is in line with the socket at the top left corner there. If you leave it like that, the ball will start riding high, and you see the ball is riding high and hitting the bone on the top, and you get what we call arthritis of the shoulder, which is secondary to the rotator cuff. So many people who have had an injury like this would have been advised surgery 7 years ago. They would have managed somehow. 7 years later they come and say, I can't lift my hand up now. They would have had an arthritic shoulder. Now instead of a simple stitch, I need to change the joint. So if you neglect it, you end up getting it changed. So it's better having your own muscle doing the job for you than replacing your shoulder. So how do we repair it? Another just animation, because some of you may be squeamish looking at the blood. So I thought animation will be better. So 2 small cuts, it's done like a laparoscopy or an arthroscopy. If you put a scope into the joint, it's called arthroscopy. So we look inside, clear the tissue there, and reattach the tendon back onto bone. How do you stitch tendon onto bone? We have devices called anchors. So that goes into the bone, and we get threads out of it. Those threads are used to fix the tendon back down. So how do I do it in real life? That's how we position the patient, and we make those small cuts around the shoulder depending on where the tendon tear is. So those are the cuts we make for various tendons, and that's the procedure being done. So that is the tear you can see. It's not working, that's okay. So that's the tendon there on the top. We are looking from inside the joint. So the white is the cartilage. The outside part, the reddish part you are seeing, should not be seen. So that's the curtain which needs to be closed down. Then you know the tendon is back on where it's supposed to be. So that is the tear. You look from the top of the tendon, you look like that. That is the tendon there, and it is pulled off from here. This is the bone where it's supposed to come back to. So how do you pull it? You release it properly. It's technically a bit challenging sometimes, but you can do it, and you have to pull the tendon back onto this bone. So we put an anchor here. You can see that whitish structure, threads coming out of that. You pass the threads to the tendon like that, and then pull it down and fix it. Now the body has to heal the tendon onto bone. That is where the body's role is. The next, you strengthen the muscle to make it work correctly. So that is before, this is after. You can see the curtain is down. It is perfectly sitting where it's supposed to be. If you look at the biology of it, they take around 12 weeks to heal. So you cannot become normal within 12 weeks after rotator cuff repair. So you need to have time, because every muscle takes long time to recover. Rehab, we put a sling for 5 weeks, so you can still do, you can use your hand for eating and everything else, but not lift your hand up, and then we start strengthening. This is where the therapists come into play, and my backbone for my practice is the physiotherapist in my team, because unless the mechanics of the shoulder, right from the shoulder blade, are not managed, the shoulder will not function correctly. I myself has had a surgery of the shoulder on my rotator cuff. I tore my rotator cuff. I play volleyball. I got it repaired. I have recovered. I am doing everything now. I still have to be more diligent with my therapy as well, and I can tell that with my own experience. Unless I don't believe in this surgery, I won't have got it done. So we started mobilizing early. In fact, after my personal experience, I thought, why not? I didn't use a sling for a long time. I started mobilizing my shoulder early, and I thought it is good, and evidence has shown that we can still do these early mobilizations, so we don't need to immobilize them for very long. That's a patient example, full range of motion. So there is a myth that if you do rotator cuff surgery, you will not have a good shoulder. You can have a normal shoulder after repair. So early detection is the key. Take home messages: injury to shoulder, X-ray is done, no fracture, but still the arm is not lifting, get to a shoulder specialist, get it assessed correctly, and scan the shoulder. You will know if there is a tear, repair the tear early. A stitch in time saves the shoulder. So if you don't go, that is what will happen. I can still make it work normally, but it is never as normal as your normal shoulder. That is an arthritic shoulder, we replaced it. That's a reverse shoulder replacement we do for a rotator cuff tear, which is not managed initially. So that's the gentleman after the surgery. So he is able to lift and everything, but the rotations are not so good. Thank you. Any questions?
Yeah. Any questions from the audience?
So looks like my message was very clear.
Looks like that. Mr. Maxwell would like to talk just for a couple of minutes. He
I have a
wanted to take a message.
Like in certain cases where like degenerative tear has happened and because of the person is asymptomatic, till the symptoms come, the problem, it keeps getting delayed, and if the joint replacement has to happen, so to what extent the muscle functions come back, or we can expect the muscle function to happen after the when the surgery is so much delayed?
So you mean to say after the joint has become arthritic already?
Yeah.
You can get a good function in the shoulder even after that, after I do a joint replacement. But with a joint replacement, it's all, your time is ticking, because it's a mechanical part we are putting in, and every mechanical part will wear over a period of time. Okay? So it's best to have your own biology or your own structure doing the job. And sometimes you get degenerative tears, as you said, where they are asymptomatic, means they don't have any problem with it, but an MRI might show a tear. Those are patients who have a strong cabling system in the rotator cuff mechanism itself, which are compensating for the small tear, and that is why they are not symptomatic. But if that tear progresses, then you will have a problem. But after a joint replacement, you can get almost 90% of the function back,
So
but
is
some
it always
rotations are a
necessary
problem.
to get the joint replacement done in certain cases, like in the asymptomatic tear?
No, no. Joint replacement is only done for pain. Otherwise, don't get it done.
Thank you.
Thank you. Yeah.
Just this question pertains to a young girl. This is a practical question which we have faced in life. At the age of 8 years, when she was playing a swimming tournament, she had meniscus tear. I thought you would touch meniscus separately with your nerve. We done only ACL and PCL, so meniscus was left out. So at the age of 8 years, she was detected with the discoid meniscus. There was a tear, then that sausage, whatever was done, it was fixed. Within 1 year, the second knee also, lateral meniscus again, it tore, and the surgery was done. My question is specific. Second surgery was done at the age of 9 or 10. So after that, if the girl is good with sports, she was good with the sports, she was good with riding and swimming, should one continue with it or not? That's first question. And second thing is, having done the arthroscopy for the meniscus tear, in the long run, what effect she would have?
That's
very challenging question.
No, that's a very good question. Now, discoid meniscus is a congenital problem where the meniscus does not form properly. The next talk is on that. Now, discoid meniscus is unstable. There are different kinds of discoid meniscus. Some of them are partial, some of them are total. When
this case, it was total, sir.
When somebody is born with a discoid meniscus, that knee is never going to be normal. Whatever meniscus is there, it is abnormal. So what we as surgeons do is to trim it and try to shape it to as normal as possible. But the attachment to the capsule to the periphery might not be good.
Correct.
Yes, they can do sports, but the surgeon has to assess and they have to plan the physio and sporting activities accordingly, because every discoid meniscus is different. It varies from individual to individual.
Second question is related to her growth. She was only 10 years old. As
Yeah.
she keeps growing, what exactly happens to the joint? How does it behave? Because meniscus generally we see, we do,
Yes.
do as happen after 18 years, 20 years, or 25 years. It's not a big problem. But for a growing child, what effect does it have?
In general, not much, but in the long term, the meniscus is not normal, it is abnormal, and the risk of arthritis coming early is always there, 100%.
Oh.
It's there.
So it's better to avoid serious sport.
Yes, that's my take on it.
Thank you, sir. I think you answered my question. Thank you very much.
At the very outset, I would like to thank Dr. Ram, Dr. DN, and the entire team of doctors at Yashoda Hospital. I think this is the need of the hour, doctor. In my 45 years of experience with sport, I have seen that many good sportsmen, talented sportsmen, have lost out on winning international medals because of the lack of knowledge on basic sports injury. I think this platform is an excellent platform. This is needed in every corner of our country, I think. If you can, in all your branches of Yashoda, if you can do something like this all across India, I think that is the footing stone and the foundation for winning medals at the Olympics. This is one of the main reasons that our country is losing out on medals at the Olympics, because they don't have the basic knowledge of sports injury. They don't treat it in time. And even after treatment, they don't follow up with the advice that you've given. And you very rightfully said that if your muscles have to be used on a regular basis, on a daily basis. I always say this: if you don't use it, you will lose it. So that is, I thank the team at TONABOLIC for your excellent teaching. And thank you, Doc, so much. It's a pleasure and honor for me to be here and part of this. I've learned so much, and I would love to be for every session of yours, learning something more and more. Thank you very much.
Thank you, Mr. Maxwell. You are a legend in sports, and those words are so inspiring and motivating for us. Thank you. We missed Dr. Sumant's session on ACL physiotherapy. Dr. Sumant, I welcome you onto the stage and give your inputs as to how physiotherapy should be done before the surgery and after surgery. Follow your 7 minutes.
4 minutes.
Please, please.
Walking.
Most of the area.
Area. PPT. Yeah. Good afternoon. I am Suman, Chief Physiotherapist at Yashoda Hospital. I don't want to tell and get you bored with complete rehab protocols. Just I want to tell where physiotherapists will come into picture. Okay, so now it's not a time bound, it's a criteria based. Okay, so what we physiotherapists exactly do is, so we act like a bridge between the surgeon and sports and conditioning guys. So we have certain criterias, and we need to follow those criterias to prevent 95% of injuries. So as we are hearing the story of Aruna Buddha Reddy, so how she got traumatized and how and we can understand to what extent mental agony she has undergone. So I definitely doubt whether she has followed the criteria based rehab or not. So now whatever thing we are discussing is a criteria. So criteria post, whenever any patient comes to us, the first thing we need to ask a patient is, who is the patient? What are the patient expectations? Okay. So the patient is a normal guy, or a patient is like a Aruna Buddhareddy. So her expectations are completely different. A normal guy, office going guy who got operated ACL, his expectations are completely different. So we need to frame a rehab according to that. So, and we need to ask certain questions to the patient. The patient will ask to us, when can I walk normally? It is a very tough question to tell, because it's not a time bound. So when can I jog? When can I run? When can I jump? When can I play sport? When can I go back to sport? And all these are not time bound. We can't just tell a patient, you can walk after 6 months, you can run after 6 months, you can play sport after 9 months. So everything is a criteria based. So what is criteria based? Our criteria for first 6 weeks will be, so the patient should have a proper activation of quadriceps. The patient should get a minimum 120 degrees of knee range, okay, and the patient should not have a minimal effusion, and the patient could able to squat 90 degrees to 90 degrees properly. He should squat that, and he should have a proper gluteal activations, and he should able to bridge completely short lever bridge. He should able to do the short lever bridge. First in 6 weeks, our goal will be non-functional bridging, non-functional loading of a ACL graft, and should able to walk normally in symmetrical. Okay, you should able to walk symmetrically. You should able to walk, and as early as possible, we should introduce static closed kinematic chain exercises. So these things are goals first. After completing these goals, then only you should move on to the next goal. Unless and until if you can't achieve these things, you can't progress to next. So when it comes to 6 to 12 weeks, it is a very key. It's the time to introduce a neuromuscular control. Neuromuscular control exercises are the key to prevent any injuries. Next, progress. Initially, I said in first 6 weeks, bilateral loadings. So in this, it's the time to introduce unilateral loadings. In unilateral loadings, it's the time to check whether you are activating your glutes, everything perfectly or not. And in these 6 to 12 weeks, you should prepare your client or your patient to prepare for jog, run and jump. For everything there is a criteria. So if you follow the criteria, you can prevent an injury. So from third to fifth week is an advanced phase. If it is a sport guy, it's the time to introduce high intensity exercises, like no abnormal walking patterns. The patient should able to walk straight 30 steps straight without any deviation in a sagittal plane, and the patient is able to do 10 consecutive squats to 45 degrees, able to do 10 consecutive squats, and we need to check 1 repetition RM, 180 repetition RM with a normal leg. We'll get to know what is 1 RM of the normal leg. On the 80% of that we need to take for an abnormal leg, operated leg, then we start introducing the weight loads on that, and slowly we can progress to next. So in late advanced phase, there are certain criteria to introduce an agility, to introduce a jumping, to introduce a hopping, to introduce the landing, cutting and pivoting. So all these games, you just to get to know what Aruna Buddhareddy was doing. I have seen her while Prem is working on her. So Prem is keep on educating her. I have seen her. So in this and her game, jumping is involved, hopping is involved, landing is very much involved. So for each and everything there is a criteria. If she can pass through that criteria, then only she is allowed to do those things. So, and next thing is criteria for agility training. Before criteria for agility training, so this neurocognitive training is very, very important. To improve the neurocognitive training, we'll be using your visual, vestibular, somatosensory systems to activate all your reflexes, and we need to create a certain environment. We need to change the ecological system. Suppose any sports guy is a football guy, he is coming to the we'll be taking back to the sports, lots of multiple people will be coming around him. So we need to create certain environment, multiple challenges we need to introduce to prevent some phobias. Okay, so for example, in agility training, if you want to introduce an agility training, you can see the patient should be able to walk 2 miles without feeling any pain and swelling, without getting pain and swelling, and the 10 consecutive single leg squat to 45 degrees without deviation and holding 75% of extra weight. This means gradually you are introducing loads on your shoulder. Eventually that causes increases load on your graft. The more load are you introducing on that, the more your graft becoming more strong. In parallel, what you will be doing? You will be doing some neuromuscular control exercises to improve your reflexes strong. Once your reflexes strong, okay, your muscle starts activating better. On top of that, you should care about your environment. So being a physiotherapist, when I am handing my case to a sports and conditioning coach, so I should be aware, and the conditioning coach should be recipient, should know the limitation. We should work in hand in hand. They should know what are the limitation of the patient, and what the criteria he has passed, to what extent the sports and condition can work on that. So we should work, and you should keep on checking their SCBT and Y balance test. Compared to normal leg, they should get a 90%. After getting a 90%, now the sports and conditioning coach is now confident to go to take it ahead. Without having these criteria, if you get them back to the sports, there is a chance of injury. So always someone was asking a question about the recreational game. Either is a professional game or recreational game. The criteria is to follow the criteria. These are the Melbourne Rehab Criteria School. We need to follow this for the prevention of injuries, for further injuries, for a better outcomes. So in neurocognitive trainings are very, very important to stimulate your visual, vestibular and somatosensory system. Integrate neuromuscular training to maintain the stability and control that helps in improving your alignment, control and stability. Introduce constant changing in environment, because your games are completely complex. You never expect what challenges will be coming to you. So environmental change, that is very, very important to keep that for prevention of injuries. And finally, if you want to send a guy back to sport, it is very important to check all the effusion, stability, range of motion. Okay, international documentation committee should be 90% when compared to other leg. You should go do some psychological assessment. Psychological scale, you should get 90%. Kinesophobia will be there. That scale you need to do. Out of 18, they should pass out with 17 points. And functional stepping test. So we need to do hop test, lateral hop test, crossover hop. Compared to other leg, you should get a 90%. Okay. Next, shuttle run test for general fitness. If the patient can do all these, if he get a 90%, then he is fit to get back to the sport. Okay, thank you. So someone was asking a question about the chiropractor and osteopath. This is just general information I want to share. As such, there is no chiropractor and osteopathic school in India. Okay, so whoever are practicing, they did some 2 or 3 days course. So better, as Ram sir said, so better be aware of your spine before getting cracked with someone else. So there is no such things. And recently we met one physiotherapist from Australia. We did one class in our college. There they said in the rehab team, means the work of chiropractor is coming down. It's an era of a muscle. Okay, you need to keep activating the muscle. So if just you manipulating the joint, you don't think that your muscles will get activated. Okay, in abroad, their work is getting down, but somehow it's booming in India. Be careful. Trust in physiotherapists, trust in your muscle to activate your muscle.
ఒకటే వీడియో ఉంది దీంట్లో.
Hello, I'm Sridhar Physio. So, as an extension of Dr. Nagasumant, I want to tell you basically about the chiropractic. Mainly it is because of muscle imbalance. Any problems comes with the muscle imbalance. So if you only work on bones, it doesn't work. So we need to work on the muscle imbalance, and then you can work on chiropractic. But at the same time, we need to work on the muscle imbalance. If you don't work on muscle imbalance though, then definitely once again, the bones or the alignment will go back. Automatically what will happen, once again you need to run to the chiropractor. So you cannot go like that. So believe in physio, and then we work on everything like bone alignment and then soft tissue management and flexibility, endurance, whatever. So please believe in it and then go ahead and be aware of quacks. At the same time, Anna, Nagasumandana. So we worked for Aruna madam, Aruna. So Asian, same, Australian Melbourne criteria. At the same time, we have done with the sports metric. But as the time goes on, the main problem was with the strength and conditioning. So that was the main lacking thing which was there. Yeah, that's why the second injury happened. Yeah, hand in hand. Thank you.
Many cyclists break their collarbones. Many cyclists break their collarbones due to impact. So my question was, is there any prehab or strength and conditioning which we could do to avoid fractures like that?
The answer is no. Cycling is a very high speed, high velocity sport. You cannot avoid injuries. Recently we know on the Italian circuit, one of the cyclists had a fatal injury. Right? I think it was Italian, I think, right? I remember. Honestly, you cannot. Okay? Right. Now, the next talk from me is meniscus. Now, it's quite personal to me. The reason is I was trained in knee surgery for many years. If you go back 15 years ago, if there's a meniscal tear, put on the list, remove the meniscus. That was the treatment of choice. 30 years ago, whenever there's a knee pain, remove the meniscus. So you will see what happens when meniscus is removed. So what is a meniscus? It's a very small structure. Look at this, very wafer thin. It covers 20 to 30% of the joint surface. Right? That's a normal meniscus there. What it does, it gives stability to your joint, number one. The second thing is, it shares your body weight. Instead of point loading, it distributes the body weight all over the surface of the joint. Now look at these two villagers. Imagine the pot is your body and the thigh bone, the head is your leg bone. If this piece of cloth is not there, the head will hurt if you catch the pot on your head. Try this at home, it really hurts. The meniscus does this job, uniform distribution of the body onto the leg bone. There are two menisci in the body, in the knee joint, that's a medial meniscus and that's a lateral meniscus. You can see the leg bone, cartilage smooth, the thigh bone, and it has to have a razor sharp border. This is how a normal meniscus looks like when I put a camera inside the joint. How do meniscal injuries happen? Just like the ACL, sports, road accidents, unsupervised training, simple deep squats without conditioning your body can result in meniscal tears. Very important. Twisting of your knee while going to the bathroom or on the stairs. Look at this tear, a big bucket handle tear. The normal one, that's a torn meniscus. What are the symptoms? The knee does not swell as much as an ACL, but it can cause repeated locking. This bucket handle tear is locked into the joint. The patient cannot extend the leg because it is locked it, and it can be very painful. Can this cause instability? Yes, because of the locking. For menisci with pain with the tears on the back side, you can get pain on deep squats, cross legs sitting on the floor. This is how we diagnose meniscal tears on clinical examination. Now we are taught this is a classification of meniscal tears, the slide in the center. But when we look at the patients, the meniscal tears are much more complex. Look at this. These flap tear, bucket handle tear, they don't fit into any of these criteria. So the injuries are much more complex than what is given in the textbooks or on Google images. Meniscal root tear is often unrecognized. It happens on deep squatting. The patients come to the clinic and say, I heard a popping sound and it is hurting behind my knee joint. That is a root. The meniscus root is torn facing you. When this happens, this is the most serious meniscal tear. The strength in the meniscus goes off. If there are any engineers, they will know what hoop stresses are. Just like the bowstring, the meniscus will maintain its strength only when it is attached at the roots, the front and the back side. Once the root is gone, the meniscus is dead unless we repair it. How do we diagnose it? MRI scans, very simple. Look at this tear, vertical, that's a normal knee. Normal meniscus, here the meniscus is torn and is locked into the notch here. It should have been here. That's a normal knee. You can see two bucket handles. One of them is a PCL, the other is a meniscus. Again, locked into the joint, the same images, coronal and sagittal sections. That's how we look at the MRI scans, from the front, from the side. Now, is surgery recommended? Why should we preserve the meniscus? This is a hot topic now in knee sports injury circles. This slide is important. If you remove the meniscus, the contact forces increase by 200% from the thigh bone to the leg bone directly, because there is no washer there. The meniscus is gone. Once it goes off, you risk getting arthritis very early, much earlier than the ACL tear. Within few years, the risk of arthritis is 15 times than the normal population. That's how important this small structure is in our knee joint. Unfortunately, all tears are not repairable. It is pale and white, it's locked, it has been there neglected for few years. I take a decision that this is the amount of time I will work to reduce the meniscus and try to repair it. If not, remove the meniscus. Yes, patients get counseled, they know that the knee is going to be arthritic, but the choice is not there. This knee is going to be arthritic in a few years. Case selection is very important. You can see how pink it is vascular. It is in a red and white zone. It's a fresh case, easy to reduce, and I can repair it pretty easily. How do we repair it? We have this classification. Depends on the vascularity of the meniscus. Red on red zone, they heal very well. Red on white, they heal very well. White on white, it's not useful. For the audience, this is the most important slide. What are the factors that influence meniscal tear healing? The time from the injury to repair, very important. The type of tear is very important. How we repair it, how we stimulate the meniscal fragment to improve vascularity is important. The number of sutures I put in will help whether the meniscal repair is going to be successful or not. And the most important, the patient has to be compliant. If the patient is not compliant and goes back to recreational sporting activities, it is not going to work. Sometimes we do get lucky. Usually up to 8 weeks after the injury, the meniscal repairs are pretty much easy to repair. But here is a student who came in after a couple of years, bucket handle tear, it is locked in the joint. I was able to reduce it. You can see the sutures on the side. He is doing pretty well. But these conditions are very rare. Sometimes we do get lucky. Meniscal repairs, how do we do it? We go shopping. 15 years ago, there was no technology, there was no instrumentation. But today, there are so many companies aware, in the market. They have got different designs, different instruments, different kits. Each company is unique in their own way. Just like the shopping, shoes, saris, jewelry, I can understand why women get so frustrated when they come back saying it's useless to go shopping, I can't find anything suitable. Exactly the same I feel nowadays. But I make it very simple. This is outside to in suture material, all inside sutures, inside out suturing. Simple, right? Depending upon where the tear is, I make my decision where to put the anchors. Bucket handle tear, red in white zone, reduce it, put in inside out sutures, put in all inside sutures. This is how it looks like initially. Once the sutures are tied, it looks like this, and that's the final result. Just a 30-second video about a bucket handle tear and how we repair it. That's bucket handle tear, reduced. That's the inside out suture. So we put multiple sutures, sometimes up to 8 to 10. That's all inside suturing material. That's how it looks like, it's very scary. Put the knots from outside. After the sutures are removed, the final result is there. This is a meniscal root tear, which is quite complex to do, but once you have the equipment, it's pretty much easy to stitch it from inside. That's after the suture has been put into the root and stitched up to the leg bone. Okay. Physiotherapy after meniscal repair is very important. It's a very structured physiotherapy regime, much rigid as compared to ACL repair physiotherapy sessions. The question is, can you return to sport? Compared to ACL reconstructions, meniscal repairs are not as strong as we think. I tell my patients, if you go back to sport, you risk 20% of tearing it again. So limit yourself, try to do some straightforward sports like cycling, running and swimming, but nothing more than that. If you try to do sports like volleyball, basketball, the risk of tearing the meniscus is very high. Thank you. Are there any questions? Or I can take them later on during the lunch. Anyone in the audience? No? Okay, I invite the next speaker. Dr. DN will talk about shoulder dislocations. Thank you.
It's amazing that you guys are still here. It's 2:30 and you're still not hungry and sitting here. That shows the interest you guys have. It's overwhelming actually. So what I'm going to talk about now will be a quick one. I don't want to take too much of your time because you're already hungry and it's never good to. So shoulder dislocation is where the ball of your shoulder comes out of your socket of the shoulder. And we should always differentiate what an instability is and what a laxity is. A lot of people are like that. You know, they can do all those sort of things. So they are not abnormal in any way. It's just that their joints are loose, that's all. So they are not dislocating all the time. Okay, dislocation is when the ball comes out of the socket accidentally and if they are painful from it. Otherwise, if they are not painful, it is not an instability at all. So human beings are in a spectrum. So we are either tight or we are very loose. So that dictates what we can do. And we talk about prehab, where you try to prevent injuries in sports. No? If somebody has a lax joint, they are relying more on their muscles to hold the joint in. So they have to work on their muscles more than the people who are tight jointed, because those joints need protection, and that secondary protection comes from the muscles. Okay? So if you are loose jointed, you have to be very, very stringent with your therapy and exercises and everything else. So shoulder, if you look at it, has a big ball, small socket. If you are a golf player, you will see there is a small tee there. It stays on the tee in spite of it being so small. So for that to stay on that, we need the muscles and the structures around it. So that's the envelope which holds everything together. If that envelope is broken, then the ball will fall off. So why does it happen? So when you have a dislocation, the rim, that is the rubbery structure you see, like the meniscus in the knee, that gets torn. And this torn stuff always heals in an abnormal position. So the defect is always remaining afterwards also. So if you are younger, means you are below 30, the chance of redislocation is very high, about 70 to 80%. If you have a dislocation at 40 years of age, your chance of redislocation is around 40%. So sports people who dislocate will keep dislocating till it is fixed. So remember that. So that's the X-ray how it looks. The ball is come out of the socket completely. That is because that rim is broken and the defect remains, and the ball keeps falling off. Our captain has this problem. He went to field in an England match, came out, that joint is out, but he's had it so many times that he pushes it himself back. So the more times it dislocates, they get the trick to get it back in place. But the disadvantage of that is every time it dislocates, the cartilage gets damaged, the tissue gets stretched, and the quality of a tissue changes. If it is a fresh one, good tissue, I repair it, you get good results, and your cartilage damage is also less. If you look inside, how does it look? That's the ball, that's the socket. It comes back in, again goes out. See that? And when it goes out, it also dents the head. There is a big dent on the head. So we were always repairing only the torn part before. Now we realized that not only there is a tear of the ligament here, but also a big dent in the bone itself. So now before I used to do only that repair. Now we are understanding the shoulder more. So I am doing a repair where I fix the socket, the ball side and the socket side. So it's two lesions, we fix them both. So why that is the case is it will stop the head from moving forward, and it will stop it from dislocating again. So this is called a name, it's called remplissage. It's a French name where we fill the defect like that. So you are reducing the arc of your head so it doesn't come out of the socket very much. So most instabilities fall into these categories. So as human beings are in a spectrum, this is a spectrum. And if you look at this bottom two, both of them do not require surgery. Only the top one, where there is a tear of the ligament or the labrum, requires surgery. So identifying this is very, very important. The rehab team is where very, very important in the lower two. So identifying this is key. And how do you identify it? By examining it. You see this boy, so he is putting his shoulder out and in, and that's a habitual dislocator. So he does not require surgery. is the last person who requires surgery. He needs his muscles to retrain to keep the ball in the socket, that's all. So if you look at the shoulder blades, I was talking about the shoulder blades being the basis of how the shoulder works. Look at that gentleman's shoulder blade and look at this gentleman's shoulder blade. So this, when you look at the arm going downwards, there is always that little drop. So he is not able to control it because the base is not strong. So you feel like it's dislocating out because the shoulder blade is not in good position. So you have to strengthen the shoulder blade also, not just So when do we consider surgery? Most of the time we do conservative if there is no trauma or a tear in the tendon or the ligament, but if there is a tear, it needs fixing. So the dynamic stabilizers are not able to hold it in because there is a tear in the static stabilizers. So the surgery involves repairing the static stabilizers, which is that envelope there. So these are, we do non-operative treatment also. It's mostly with the therapy point of view, where we strengthen all the muscles around the shoulder blade and the ones which are holding it. That is the secondary stabilizers, that's the rotator cuff. So we used to do open surgeries for this, but now the gold standard is arthroscopic surgery again, where we actually go in, repair the structure inside, again small cuts in the shoulder itself, and we get to that area which is torn and we fix it with an anchor. So 2 small cuts, I do it from 3 small cuts. So this is the normal cuts I give for my shoulder arthroscopies. You can see that's the torn labrum there, and this is the surgery. We make small cuts, pass the sutures through that, we look from the back and then repair the structure itself. That is the labrum which is torn, and these threads are going in from where the tissues are torn. We lift it up, we pass it through with small devices through that, and these threads are passed in and we tie them up completely so that you get a nice bumper in the front. So this is the technique I use, which is called, it's a more complicated one, a Bruma, where you get a real good bumper. So that bumper is good, then the stability is better. So this thread is taken out with that suture retriever. So we just pull it out through that. So it goes down and you have all the threads there. Once you tie it, it will all hold that bumper up and give you the tension in the shoulder itself. So that's how we tie it. So we put a knot and push it in. So after that is pushed in, you will see the bumper is nicely recreated now. So do patients go back to sport after surgery? That is the point you all want to know. They do. So not only my experience, literature supports it. 8 studies they looked at return to sport, 70% of them do. There are the 30% who do not. I don't know the exact reasons why they do not, but there may be other compounding factors at their therapy and everything else. Okay. And 90% go back to their previous level of sport. So this gentleman is in the audience. He is my patient. He had a bank card repair done. Swarnendu, he is a national level TT player. I will show him in action. He had a clavicle fracture and then he also had a bank card done and a rental. And he is left-handed, it's his left hand. Thank you, Swarnendu, for coming. You want to have a few words and go? You want to come down? And this is my other patient. He is a gymnast. Apparently, he just won the medal recently. I operated on him about 1.5 years ago. It was a revision surgery. He had a surgery done once. It failed and his confidence was completely down. So we did a revision surgery. We fixed it and now he can do all this. And the coach who came, Manoj, was telling me just now that he was very happy that he won a medal in the national level recently. So I am happy that I helped him out. So Swarnendu, please.
Hello everyone. So the first time I got my shoulder dislocation, it was in 2008. So that was a recurrent one, and the last one, it was in 2017. And that was,
Yeah.
Yeah.
Talk in this only, but
so that was, I was just simply sleeping and I just sneezed and that came out. So that was the time I thought that I definitely need one surgery. And after the surgery, it was 6 months. I did rigorous rehab under Dr. Prem. Thank you very, very much. I mean, I feel 30% is the surgery and the rest 70% is the physio.
True.
Like that's like
Agree.
Too much. So I feel right now I'm playing the best table tennis of my life, and I thank you really for that.
You're welcome.
Thank you very much. So that's all. Thank you very much.
Thank you, sir. So we'll go back to the presentation. Yeah. So not all of them require only soft tissue procedure, because if you have repeated dislocations, the bone is eroded, right? So we have a scoring system how we find out, and that's where I come into the decision making point of view. For example, if somebody is so lax, this guy is a 19-year-old wrestler who had a very lax joints, and if you look at his bone, part of his bone is lost there. Normally the glenoid, the socket, has a beer belly. The beer belly is missing and he has a flat stomach there. That means there is not much support, so the ball falls off. So you need to increase the ball, the surface area of the socket itself. How do you do that? We transfer this bone here. So the bone which is on the top there, we put it here and increase the surface area. So this decision making is again based on surgeon's assessment. It's a small video, but we do it through a small incision that size. And that's the X-ray after surgery. You can see those two screws holding that bone, and you increase the socket size there. So identify the type of instability, assess them properly and treat accordingly. And rehabilitation is the key, as Varnendu also just mentioned. Thank you. Now I invite Amit to talk on foot and ankle and some exciting orthobiologic stuff.
Good afternoon, everyone. I'm glad all of you are here, and I'll not keep you waiting for lunch for long, and I'll go ahead with this presentation. So yeah, for those of you who don't know me, I am properly from Hyderabad, and I've done my schooling and everything here, and then went on to do my post-graduation and other things. And later on I did a fellowship in arthroplasty, and then for my further education I went to Switzerland, where I did a fellowship there, where I learned about the more subspecialty work. So over the last 10 years we've been together fixing most of the fractures and other things where possible, and where we cannot, replacing them. And over the years we've treated patients from all across the world and won a lot of accolades for it, and it's been a good journey so far. But yeah, one of my main key interests is saving the joint. And so what is the problem that normally happens there? It's the cartilage wear and tear leading to inflammation, causing free radical release, oxidative stress, and finally cell and tissue damage. Many times we have these patients who ask us, sir, how can we stop cartilage damage. It's very simple, stop aging. But is that possible? No, it's not. Unless you are this guy who's a billionaire using millions to reverse aging. I wish him all the best. That's him with his son and his father. Coming to the conservative options, or multiple options, weight loss and exercise, especially strengthening exercise, is known to be the single most important thing which prevents cartilage wear and tear or damage over the years by conditioning the muscles and strengthening the muscles and increasing the tone. So when the damage happens, multiple processes are involved, wherein the end result is decreased aggregate proteoglycan and collagen within the cartilage, and ultimately leading to pain, muscle weakness, stiffness, and reduced mobility. So our intention here from the exercise point of view is to prevent this muscle weakness and thereby lead to stiffness. So multiple kinds of exercises are there which are being proven to help in relieving this pain. Aerobic exercise relieves pain and improves physical function. Strength training improves muscle weakness. Neuromuscular exercise and balance training helps in proprioception and maintaining balance control. Aquatic exercises have been proven to be helpful, and traditional exercises are also helpful, such as yoga and etc. The other thing is bracing. Even superheroes need bracing sometimes. If you've seen Dark Knight Rises, you will see Batman wearing the knee brace and then crime fighting. So they help in offloading the joint, especially the place where you have this damage. But the problem with these braces is they are either uncomfortable or sometimes expensive if you look at the very good ones. And in the Indian population, out of my personal experience, people do tend to buy them, but later on stop wearing them because of multiple reasons. Probably being uncomfortable is one of the most common things. Medicines, yes, NSAIDs, COX-2 inhibitors, these are helpful, but they should not be taken on a regular basis. Can be used as an occasional pain relievers. Supplements, chondroitin sulfate, glucosamine, these are fairly available off the shelf in most places. If you look at the review, the current literature and data, they have not been proven to be any more effective than a placebo therapy in most cases, and since they do not cause any damage or not known to cause any side effects, they are fairly in use. Diet, there are multiple studies which have been conducted and found to be helpful in preventing cartilage damage. The base philosophy here is reducing inflammation, saving the cartilage. And something like curcumin, vitamin C, all these things help in reducing the inflammation and thereby help in preventing further cartilage damage or at least slowing down the cartilage damage. What about mildly invasive things, injections? So we have the commonly used ones are hyaluronic acid, which is basically an artificial hyaluronic acid which is injected into the knee. The philosophy here is it reduces the inflammation, helps in stabilizing and maintaining the cartilage. Cortisone injections or steroid injections, they can be used for acute pain relief or sometimes in synovitis cases, but on prolonged use or regular recurrent chronic use, they are known to cause cartilage damage or rather enhance cartilage damage. This is one of my patients on the X-ray that you see on the left top side. The left knee is a normal knee, whereas the right knee, the damage got progressed because of repeated corticosteroid use. What about PRP therapy? I am sure everyone would have heard about it or at least come across it. The concept here is taking your own blood, processing it, separating the platelets and then injecting it. And once we inject these platelets, they rupture, release growth factors and help in healing, or rather actually it's the reduction in inflammation, thereby preventing or reducing the joint pain. What does the current data say about it? There are multiple studies, some which are fairly recent ones. Ultimately, all these things prove that level 5 evidence is still pending though, but they help in reducing inflammation and reducing pain to some extent in grade 2 and grade 3 stages of arthritis, and in grade 4, when they compared it with hyaluronic acid, PRP and placebo, there is no evidence of any improvement or rather growth of cartilage. So bottom line, PRP reduces inflammation, decreases pain, it does not grow cartilage. Bone marrow aspirate. This is also a kind of a therapy wherein the bone marrow is aspirated, cultured and then injected. But the long-term studies have not shown any more benefit as compared to a PRP injection. The concept here is that the live stem cells have a higher growth factors and probably give better relief. But do all these things work when we have a deformity, when you have bowing of the knees? No, they don't. And I'm sure most of you would have come across ads like these, wherein they claim 100% relief. You can see the poor woman there. I don't know if she's crying with pain or because she lost her money trying to get one of these treatments done. What are the surgical options? So in mild to moderate defects, this is one of my patients where you see the cartilage damage there in early stages on the left slide, on the right slide. In these cases, we do something called as chondroplasty, wherein we make multiple small drill holes, and over a period of time, cartilage forms there. But the cartilage that forms this way is composed of fibrous cartilage. The natural cartilage is hyaline cartilage. It does the job, it reduces the pain, prolongs the life of the knee joint. This is ideal when there are mild damage with very few areas of defect, and provided the joint alignment is still fine. This is another patient where we do something called as an OATS or osteochondral autograft transfer. We take healthy cartilage from certain areas of the knee joint, like you see here on the top right, and transfer it to the defect areas, and post that it heals over a period of time, thereby getting them back to their normal activities. Again, the main indication here is, one, there should not be any abnormality in the bones. I mean, there should not be any deformity. At the same time, there should not be any inflammatory conditions like rheumatoid arthritis and those kind of things. So this is a patient with the defect initially and then after the surgery and the repair. Another one is what we refer to as autologous chondrocyte implantation. This is useful where we have a large defects. Here you see the defect, that's the femoral condyle on the top, and this is underneath the patella. The patient was an athlete, he was in the army, he's a mid or late 40s patient, wherein we have, it's a two-stage procedure, where in the first stage we take the cartilage, culture it through a process, and then we put it back into the damaged area. And the cartilage grows back to a certain extent, wherein this acts like a scaffold. There are other newer ways called biocartilage autograft and all that. So these are kind of a combination of the above mentioned treatments. Cadaveric allograft is not yet allowed in our country, nor the facility exists. So what do we do in deformities like this, where there is abnormal loading, and because of the abnormal loading which leads to pain? The patient you see here is a national level kabaddi player, and he was suffering from pain because of the abnormal loading and the deformity. So in these cases, we try to correct the deformity through surgery. This is what we refer to as a high tibial osteotomy. Now, just correcting the deformity alone is not enough. Sometimes we may have to do additional procedures. For example, repairing the meniscus, repairing the torn meniscus, or repairing the ligaments which are concurrently damaged. And we may also have to do cartilage transfer along with deformity correction. But what about deformities like these? Do any of these work? No, not really. Knee replacement becomes the only choice with a successful result. Other area that I would like to touch upon is the spine and disc related issues. So I'm sure most of you would have come across these cases wherein there is a disc bulge or a disc rupture leading to pain. The initial pain actually occurs because of rupture of the disc and the material that comes out and the severe reaction that it causes. In these scenarios, initially it has to be treated conservatively unless there is a neurological deficit, and this is by medication, pain relievers, analgesic and anti-inflammatory medications. And again later on, once the initial pain subsides, physiotherapy is what we start, that is strengthening exercises, conditioning exercises. The MRIs, so what is the natural history of these things? So what happens? So here you see when it initially ruptures, that's how it looks like. But over a period of time, the disc dehydrates, the ruptured disc. And ultimately, it doesn't cause you any pain. So in fact, these are my own MRIs wherein I had these issues. This is in fact my wife's MRI. I could treat her without surgery. Now, in these cases, it becomes important for us to manage the pain initially so that the rehabilitation can be initiated. There are multiple ways to manage this pain initially, and there are like lumbar epidural injections, transforaminal blocks. These are fairly simple procedures which can be done on a day-care basis, and there will be instant or immediate pain relief, following which they can rest it for a while and start with the therapy. Arthritis not just affects the knees or hips, but it also affects the spinal joints, or what we call as the facet joints. A similar treatment here, a facet block can be done to relieve the pain, and later on the conditioning and strengthening exercise can be initiated. In cases where there is a recurrence, what about that? In such cases, we can do something called as a cooled RF ablation, which basically numbs the nerve endings, thereby reduces the sensation of pain. And how long does it last? It can give you pain relief anywhere between 6 months or sometimes a year. And during this time, once you start with the strengthening exercises, the risk of recurrence is reduced. And sometimes in failed back syndrome or cases post-surgery wherein there is a recurrence of pain, there also these modalities of treatment can be used. Thank you all, and any questions, please feel free to ask me. So I think everyone's hungry and probably waiting for the lunch, so we'll just head there. Thank you.
Thanks to everyone who have made it to this meeting. I hope all of you have taken some educational points to take home. Let me thank once again Ashrita and your team. It was a small idea which has turned out this big, and Mr. Maxwell, he has left, but what he said is true. There are not many rehab teams in this country, and that is the need of the hour. Hopefully there will be more awareness and more educational programs like this from now onwards. We will keep trying. That's all we can do. Thank you. Kaja, come over. And a few mementos to some of our senior coaches and to Ms. Ashrita.
I would like to invite Dr. D.N. Reddy and Dr. Venturla Ramohan Reddy, Dr. Nitish Ban and Dr. Amit Reddy to give mementos to Ashrita Datta. Next, John sir, can you come to the dais and take the mementos?
John sir is our national swimming coach. Not many are aware of what he does. His academy, Zion Sports, is just few kilometers from here. He has produced many, many national champions, and some of them are going to the international circuit. Vritti Agarwal is one of his students. She is just 17 and is already made to the Asian Games. Right? I have known John sir for the last 10 years. More than the students, the parents are scared of him. Thank you, sir. Please come over, sir.
I just want to say a few words. I've known Dr. Ram sir from the last 12 years now. And Vritti had an injury for 8 months. And I took Dr. Ram's help. And with Prem, physio, Prem sir, and Dr. Ram, she is doing well now, and she's going for the Asian Games tomorrow morning. She's leaving. Thank you very much.
coach.
I invite to Aruna. Can you come to the dais and take the memento, please? Next, Manoj Rana, the national gymnastic coach, come to the dais and take the memento, please.
Mr. Manoj Rana is our national gymnastics coach. Right? He has produced another champion. Her name is Nishka Agarwal. She is just 15 years of age.
I invite to Srikanth, sir. Can you come to the dais and take the memento, please?
Srikanth sir is a head coach for DPS schools. He is also a national NCC tutor for the state. He won the triathlon for the state in 1997, and the record still stands. No one has broken it so far. Thank you, Srikanth sir. ఒక్క నిమిషం చూస్తాను. మీతో వాళ్ళు వెళ్ళిపోయినారు. మ్యాక్స్వెల్ ట్రావెల్ వెళ్ళిపోయాడు. వెళ్ళిపోయాడు ఆయన. Okay. Mr. Maxwell and Sunil Menon, who was the first Ironman of the state, they have left. We will send the mementos to their offices or homes. Thank you. Thank you all for coming over. And please come and have the lunch. If you have any queries, any doubts, you can always reach us. All right? Feel free. Right? Right? All right. Thank you, sir. Thank you for inviting us. I hope you have taken something home. Right? Thank you.
రామన్న